This conference will now be recorded.
Well, since I hope everyone is here and we have a lot to cover, we really should begin today's webinar. I really appreciate you all for attending today. A very good morning, afternoon, or evening to one and all present here virtually with me today. Let me introduce myself. My name is Razina, Conference Secretariat at Coalesce Research Group LLC, and I will be available for any of your queries or questions throughout the webinar to help you out technically and organize the webinar successfully. For the next few minutes, please allow me to give a brief description about our organization, Coalesce Research Group, and also the further instructions. Coalesce Research Group LLC is very delighted to welcome you all, the speakers, supporting associations, students, and delegates present virtually with us today, with the aim of mark the scientific excellence by facilitation conversations, sharing knowledge. Coalesce Research Group follows through the objective of setting standards in delivering excellence in the research among the researchers, academicians, and industries, promulgating the research through conducting events and online webinars from various fields of science, especially from the stream of medicine, science, engineering, and technology. Within a short duration, we have succeeded in creating a platform for developing a strong professional network with the people across the world from the respective fields that they haven't connected in a while. And As a global scientific event organizer, we plan and carry out international conferences, meetings, seminars, symposium, and workshops, providing the best delegate experience, excellent networking opportunities, conversations leading to innovations, learning new opportunities, lasting working relationship, and professionalization with the professionals around the global network. Just recently, we have also started our own platform for open access peer-reviewed scholarly literature, where all the content is freely available without any charge to the reader. We aim to share the new recent advances through scientific publications, which will help in minimizing the borders and contributing the use of research works of eminent authors, scientists, researchers, research scholars, students, etc., across a broad spectrum of medical, clinical, pharma, and engineering scientific disciplines and its subspecialties to promote the ideas, which will further guide the development and facilitate the use of scientific information and ensure its quality, and also will be connecting link between researchers and scientific community. We are committed in ensuring that our journals are disseminated worldwide so that the researchers are able to access our content wherever and whenever they need it. As being a very few journals, we have coined up some interesting journals and have also formed the editorial board. And we will be very glad if any of our today's attendees, that is speakers, students, or delegates, could extend your support by checking the journals and will be interested in publishing an inaugural issue at any of the journal according to the area of expertise. We will also send an email with the details of the journal after the commencement of the webinar. To take your time to check the website. Finally, I would like to thank the attendees of participants of today's webinar and hope you enjoy the webinar and gain knowledge from the sessions today. We also hope your participation will contribute to new research findings and that will lead to new collaborations and research initiatives. Before we start with the sessions, I guess some of you will be new to the GoToMeetings app. Let me just explain you the important tools required for the presentation. On the GoToMeetings app or web page, you can find four icons at the bottom of your center of the screen, that is mic, camera, screen, and end. Mic. Click on that button to mute or unmute yourself. I request you all to stay muted while our speakers are presenting their research work so that it doesn't cause any disturbance to them. Camera, you can use this button to share or unshare your web camera. If you have the option to share the webcam, you can do it, and it is completely of your choice. Screen, you can use this button to share your screen. This is the main part during your presentation. After I call your name from my side, I will be making you the presenter, and only I give the permission you will be able to share your screen with us. So once I make you the presenter, you can click on the screen button and you will find a pop-up window to share your screen. And this is your fourth icon where you can use this to leave the session. On the top right corner, you can use the options to change your display settings. At the top right corner, you will have three icons, that is people, chat, and settings. In the chat option, you can chat with me or any other participants. For the settings, you can use this button to check for the settings of your speakers and microphone. So as mentioned, kindly remain muted during the presentation so that the presenters don't get disturbed. And for any questions, you can ask the questions or you can send your questions in the message box too. Well, let's not take much of your time. Finally, I would like to request you to please give a brief description about yourself before starting the session so that we can know about you virtually. And now let's move into our sessions of today's webinar. And our first webinar presenter is Dr. Adam Wisniewski from Nicolaus Copernicus University, Poland. Hello, Dr. Adam.
Hello, good
Welcome.
morning.
Good morning. Are you ready with your presentation?
Yes,
Yes. So I'm going to
I am
make you the
ready.
present. Yes. I'm going to make you the presenter. Yeah, it's done. Please click on the screen button and share your screen with us. Yes, it's visible now.
Okay, but I can see this presentation. I'm not able to see my presentation.
Not able to see your presentation, but it is visible to us.
It's visible, okay.
Yes.
So if it's visible, I can start, I think, okay.
Yes, yes, it is in the first slide. We can able to see that. Yes, yes.
Yeah, okay. Thank you for introduction. Well, as a representative of organizing committee, it's a great honor for me to welcome everyone on World Congress on Neurology. So good morning, good afternoon, or good evening, depending on your place in the world. So I hope we will have a magnificent time during this Congress. I think that all the presenters will provide significant data, increasing the knowledge in the field of neurology. I would like to welcome all active presenters and participants and all registered attendees on this World Congress on Neurology. I think we will have an opportunity to exchange the experience and discuss the current research trends in neurology. We know that it's a very difficult time due to a pandemic, but we can use the advanced technology to meet each other, and it's a great challenge. And I wish good luck to all the presenters, and I believe that this Congress, thanks to you, will be a great success. So I can start my presentation. Let me introduce myself. Well, my name is Adam Wisniewski, and I am an assistant professor in Nicolaus Copernicus University in Toruń. And I'm a head of stroke intensive unit in our department of neurology. And for many years, I'm interested in stroke, in particular in platelets, in antiplatelet agents, efficacy and safety based on platelet reactivity. This is my general research interest. And today, I would like to ask you to hear my keynote presentation, the influence of risk factors and gender on platelet reactivity in stroke and transient ischemic patients. So we can go on. So as you know, platelets are morphotic elements mainly responsible for stopping the bleeding. But during some circumstances and in some cases, the platelets may become hyperactivated. And hyperactivation of platelets is very dangerous because hyperactivated platelets may cause atherosclerotic changes in blood vessels, and it can lead to ischemia of heart and of brain, and leading to resulting in ischemia of the brain, so the stroke. Why the platelets are so dangerous? As you can see, hyperactivated platelets may produce a lot of different substances responsible or engage in inflammation, proteolysis, or thrombosis process. And all these substances may speed up the atherosclerotic process, so speed up the thrombus production and resulting in formation of clots in blood vessel, and it can lead to stroke or transient ischemic attack. As you can see from this slide, we have a lot of different agonists of platelets leading to hyperactivation. One of the strongest agonists of platelets is thromboxane second, yes. And the most common used drug, antiplatelet drugs, so acetylsalicylic acid, so aspirin, has its antiplatelet effect based on stopping of production of thromboxane. The effect is based on reduction of cyclooxygenase 1 that can stop the transformation of arachidonic acid to prostaglandins. And prostaglandins lead to production of thromboxane. And if you don't have so much thromboxane, you don't have hyperactivated platelets. That's why this is the mechanism of action of aspirin. And all the neurologists interested in stroke probably know the current guidelines of American Heart and American Stroke Association from so they were updated 2 years ago. Yes, and we know that administration of aspirin is recommended in patients with acute ischemic stroke within first 24 or 48 hours after stroke onset. Of course, this treatment can be delayed when the patient underwent the intravenous treatment with alteplase. In some cases, so patients presenting minor no cardioembolic ischemic stroke with National Institute of Stroke scale below 3 points, so 3 points or below, and who didn't receive alteplase, we can start the patient combination treatment, so aspirin and clopidogrel. But as you can see, this combined treatment has a short time because it can be continued for 21 days, and then we have to come back to one drug. And as you can see, the other drugs, despite of aspirin or clopidogrel, still are not recommended. So inhibitors of glycoprotein receptors, ticagrelor, still are not recommended for secondary prevention of stroke. That's why all the patients who has a non-cardioembolic origin of ischemic stroke, we should use antiplatelet agents rather than oral anticoagulation. And this treatment is to reduce the risk of recurrent stroke and other cardiovascular events. And of course, for early secondary prevention in patients with ischemic stroke, the selection between aspirin or clopidogrel, because only these two drugs are generally suggested or recommended, the choice or the selection of the drug should be individualized on the basis of patient risk factors profile, cost tolerance, relative known efficacy of the agents, or other clinical characteristics. And aspirin, increasing dose of aspirin or switch antiplatelet agents is not well established. We have some studies, some clinical trials showing that in patients with non-cardioembolic stroke, there is no superiority of oral anticoagulants over aspirin or clopidogrel. But as we know for our clinical practice, most of the patients, about 70 up to 90% of patients after stroke receive aspirin as a prophylaxis of recurrent vascular disease. So aspirin is the most common antiplatelet drug used in the world for secondary prevention of stroke. And one of the phenomena that may significantly reduce the efficacy of aspirin is the aspirin resistance. Well, the definition of aspirin resistance is still well not established, but we generally think that aspirin resistance is the reduced platelet sensitivity to aspirin therapeutic effect. So we may say it's ineffectiveness of the drug. We may say it's a failure of drug therapy. We may say it's a variability in responsiveness, or it's a low response in some circumstances. And we may subdivide aspirin resistance into biochemical and clinical. The biochemical is based on assessment of platelet reactivity. And we may say that aspirin resistance is the same like high on treatment or high on aspirin plateau reactivity. And you can see the incidence is from 3 to 50% of the patients. And in most cases, this biochemical aspirin resistance is translated into clinical aspirin resistance when despite of regular treatment with aspirin, the patient has a recurrent new vascular events. And you can see that the incidence of clinical aspirin resistance is from 5 to 65%. The mechanism of aspirin resistance is very complex. We have some different factors related to increased risk of aspirin resistance. So we can see first we have pharmacodynamic factors like hyperlipidemia, oxidative stress, hypoglycemia, or chronic inflammation processes. So we all know that these processes are very common risk factors or cardiovascular risk factors of stroke and heart disease. Then we have also pharmacokinetic factors like non-regular aspirin treatment, disorders of absorption, hypermetabolism, low levels of drug, and drug interaction, especially I think about ibuprofen, another drug used for anti-inflammatory reasons. Because ibuprofen may compete with aspirin for active place. That's why this drug interaction may increase the risk of aspirin resistance. Then we have environmental factors like smoking or lack of physical effort, and very important genetic factors. So there are not modifiable factors like polymorphism of genes of cyclooxygenase 1 and 2 or thromboxane, leading to produce enzyme with changing activation center that may effectively block acetylation made by aspirin. So the aspirin may not have an active mechanism of action. Or we may have expression of isoform of cyclooxygenase 2 that is not reactive to aspirin. And as a result of synthesis of thromboxane 2 is increased. So generally, we have to remember that the mechanism responsible for aspirin resistance is multifactorial. We have factors that reduce aspirin bioavailability. We have alternative pathways of bladder activation. We may have genetic variation, not modifiable for us, and we may have accelerated platelet turnover. And due to this multifactorial background of aspirin resistance, this phenomenon is so common, I think. To assess bladder function, we have a lot of different platelet reactivity tests or assays. And here you have the most common types. And as you can see, most of the tests based on aggregometry. So we measure the level or the intensity of aggregometry. So a tendency of platelets to aggregate. And we may have impedance aggregometry, so it's a multiplate. We may have optic aggregometry. This is a light transmission aggregometry. We may have study of aggregation and adhesion of platelets in uncoagulated blood under condition of arterial flow. We have turbidimetric aggregation, so verify now. We have flow cytometry, thromboelastography, and flow aggregometry, so it's a bladder function analyzer 100. And 3 years ago, there was a new paper showing expert consensus on platelet reactivity testing, especially in cardiology. And the experts say that this test marked in red, so impedance aggregometry, turbidimetric aggregation, flow cytometry, and thromboelastography are the tests of choice. And they are standardized and validated. That's why we can use this red test as a standardized procedure. So it's very, very important that some of these tests are now standardized, and we have different cutoff points to estimate and to evaluate high platelet reactivity. So we are performing platelet reactivity testing to estimate high on treatment platelet reactivity. This is the same like drug resistance. So when you measure, so we have a patient and we test platelet reactivity, and when you have very high levels of platelet reactivity, it means that you have a high on treatment platelet reactivity, and it means that the inhibition of platelets is not sufficient, is not effective, and you may have an increased risk of drug failure in the situation. On the opposite side, when the levels of platelet reactivity are very, very low, so it means that the inhibition of platelet is too strong, and it may lead to bleeding consequences. That's why the results of platelet reactivity in normal means that the treatment, antiplatelet treatment, is effective and safe. That's why the tests of platelet reactivity may be very useful. And here you have some representatives. So light transmission aggregometry. So this is the optic aggregometry, when you measure aggregometry in the solution of platelets. And of course, when the aggregation is high, you have a higher results of aggregation, yes? And the results over 20% means that you may have high on treatment platelet reactivity. Another device is multiplate, so impedance aggregometry. So between two electrodes, you have activation of platelets, and this electrical resistance is transformed into units area under the curve, and if you have higher levels, higher units, it means that the activation of platelets is too high, and you may have aspirin resistance. Another device is Verify Now, and here we can estimate aspirin reaction units, and as you can see, the cutoff point is 550 units, and when you have higher levels, it means that you may have a drug resistance. And the last test showing you is plateau function analyzer 100, and here we estimate a closing time. So this is the time for platelet plaque to close the central opening, and this is a measure of platelet reactivity, and the levels below 193 seconds is defined as aspirin resistance. So we know the definition of aspirin resistance, and what are the clinical consequences of this phenomenon? We have a lot of paper showing that aspirin resistance or high on treatment platelet reactivity is associated with increased risk of recurrent vascular events, with poor clinical condition, with higher volume of ischemic focus, with more acute ischemic changes in sequential magnetic resonance imaging. So the patient may have new ischemic changes when the patient is aspirin resistant. Aspirin resistance also associated with higher mortality and with higher risk of sudden death. That's why we perform our own study to assess the relationship between platelet reactivity, vascular risk factors, and gender in patients with cerebral ischemia. And we included 101 subjects. Most of them met the criteria for diagnosis of ischemic stroke, and 32 patients were with transient ischemic attack. So they have an ischemic focus in the brain in magnetic resonance, of course. And all the patients were candidate and were treated with 150 milligrams of aspirin. We have, of course, exclusion criteria, so a lack of patients consent to participate in the study or inability to express it consciously. For example, patients with aphasia or quantitative disturbance of consciousness. We excluded patients with embolic cerebral ischemia, for example, with documented atrial fibrillation, because as you know, these patients are candidates for oral anticoagulation, and the treatment with antiplatelet drugs is not recommended in this group of patients. We exclude the patient with oncological history because we know that neuroplasm may activate the platelets and may interfere with our results. Patients were taken aspirin before admission, yes, because we wanted only to have a patient where the treatment, antiplatelet treatment, is something new, yes. Receiving aspirin before admission, yes, may also interfere with our results. Patients with chronic inflammatory processes that may also affect the results of platelet function, for example, chronic venous thrombosis of lower limbs and chronic lower limb ischemia. Patients who had an incident of stroke or transient ischemic attack in the previous 2 years, and patients with significant bleeding in the last 2 years, and patients with thrombotic and low value of hematocrit. And we use impedance aggregometry, so multiplied platelet function assay to estimate platelet reactivity. And here you have our criteria for sensitivity and resistance to aspirin. So when the patient, like here, had very low levels of aspirin reactive units, it means that the inhibition of platelet is very, very good. Then we have semi-sensitive patients to aspirin from 30 to 40, yes, like here, and we have the patient resistant to aspirin. So the levels of area under the curve over 40, like here, means that activation of platelet treated with aspirin is too high, and it means that the patient is aspirin resistant. And here we have a comparison between stroke and transient ischemic patients in age, in gender, in risk factors, and in laboratory results. And you can see that in general, I think because of a similar pathophysiology process, we didn't find any important differences between stroke and transient ischemic patients. And here's our level of or the incidence of aspirin resistance. So you can see it's almost 31%. And of course, most of patients were sensitive. Some of them were semi-sensitive, but we have also 1/3 of patients were aspirin to resistance. Here we have a distribution of sensitivity and resistance for aspirin between a comparison between stroke and TIA patients. And you can see that generally the distribution is the same. So the most common group was the patients sensitive to aspirin. In general, the patients with stroke had a little higher results of platelet reactivity compared to transient ischemic attack, but these differences were not significant. And here's the first very important result for our research. So as you can see, a comparison between men and women. And as you can see, the men had higher platelet reactivity compared to women, and the results were significant. The differences were significant. Another differences, as you can see, is a distribution of patients resistant and sensitive to aspirin among men and women. As you can see, in men, we have a similar group of patients resistant and sensitive to aspirin, while in women, the number of patients sensitive to aspirin is much more higher compared to patients aspirin resistant to aspirin. And our results were not first because similar conclusions were drawn by Jeremy et al., who also showed that in population of men with ischemic stroke, the platelet activation assessed by a different method was a flow cytometry, but also in men, the results are higher in platelet activation compared to women. And what are the explanation of the dependence of platelet activity on gender? Well, I think it could be a hormonal basis, yes, because it has been shown before that testosterone increases platelet reactivity or platelet aggregation, while estrogens and progesterone in women inhibit platelet aggregation. So it could be an explanation of our results. And of course, greater platelet reactivity in male gender may also partly explain why incidence of stroke is lower in women and why stroke occurs in women at a later age. And another point of our results are cardiovascular risk factors and platelet reactivity. And as you can see, only smoking was the only risk factors where the differences between group with absent and present of the cardiovascular risk factor were significant. Here we have the comparison between active smokers and patients who are non-smoking. And you can see that smokers have a significantly increased platelet reactivity compared to patients who are non-smoking. And here you have also a difference between current smokers and non-smokers. Yes, current smokers, as you can see, the significantly different distribution of patient resistant and sensitive to aspirin. In smokers, we have more patients resistant to aspirin, while in non-smoking, the number of sensitive to aspirin is much higher compared to resistance to aspirin. Other researchers also conclude that nicotine addiction is more common in patients with stroke, yes, and it's more common in patients with aspirin resistant. And we have some different explanation of such a phenomenon. We know that nicotine addiction intensifies platelet aggregation, yes, So it's very important. The researchers show that smoking-free cigarettes quickly in a row increases the ADP-dependent platelet aggregation in vitro. Yes, smoking also activates the expression of PET-selectin on the surface of platelets, and of course it can stimulate platelet activation. And in addition, regardless of the mechanism leading to modification of platelet reactivity, smoking cigarettes, as we know, increases blood viscosity, blood pressure, and reduces cerebral blood flow through a vasospasm. That's why nicotine addiction rises the risk of stroke on average from 1.5 to 3 times. So here we have the conclusion from our study. So the prevalence of aspirin resistance in our group of patients was estimated at almost 31% by means of impedance aggregometry. We didn't find differences between patients with stroke and transient ischemic attack, but we showed that male gender smoking associated with greater reactivity of platelets and more frequent occurrence of aspirin-resistant patients with aspirin resistance. That's why we have to think about platelet reactivity testing as a diagnostic procedure in stroke. Should it be that procedure? So I think we can use platelet reactivity testing, especially in some group of patients. For example, patients with recurrent ischemic events despite regular aspirin treatment. Smoking males with blood vessel disease, so with carotid artery stenosis, because it's a group of risk of increased platelet reactivity. So I think in general, we have to think about personalized or individualized antiplatelet treatment in stroke based on platelet function. The same situation is in cardiology. We have some point of care tests that are preferred. Yes, I showed you this test, and selection of assays should depend on local experience and availability. And we should use, of course, standardized and validated platelet function assays, because, as I said, they may provide a significant and prognostic data for cardiovascular risk prediction. And based on result of platelet reactivity test, we can escalate or de-escalate the treatment. So we can make escalation of treatment when we have increased risk of increased levels of platelet reactivity, because it means that the patient is at increased risk of thrombus, increased risk of recurrent vascular events. On the other hand, we can de-escalate the treatment when we have very low levels of platelet reactivity, because it means that the patient in this situation is at increased risk of bleeding. That's why we can, based on platelet reactivity test, we can modify the treatment. We can switch the treatment. Yes, we can increase the dose. We can do anything for the patient to increase the efficacy of the treatment. And please remember that in stroke, the efficacy of antiplatelet treatment is essential for the patient. That's why we can monitor the platelet function to enhance this efficacy. What can we do? We can try to increase the dose of aspirin. We know that normally we use usually 100 or 150 milligrams a day of aspirin. We can try to increase a dose to 300 milligrams. I think it's a maximum daily dose of aspirin, but could be safe, because we know that increasing dose of aspirin is increased risk of bleeding. But I have seen some papers showing that increasing dose of aspirin may break aspirin resistance. So it can be one of the choice. we can try to switch aspirin, to switch the patients treated with aspirin to clopidogrel. But please remember that clopidogrel resistance is also a very common phenomenon, and most of the factors are the same. Most of the factors related to clopidogrel resistance. That's why some of the papers show that patients treated with aspirin are at increased risk of clopidogrel resistance, and coexistence of aspirin and clopidogrel resistance may be observed in up 50% of cases. We have a lot of studies or clinical trials on ticagrelor in prevention of stroke, like Socrates, like Taylor's, but at this moment we don't have, ticagrelor has no superiority on aspirin and may be connected with bleeding events. That's why still today it's not recommended, but maybe, of course there are some trials showing combination treatments. So maybe ticagrelor with aspirin will have a superiority on clopidogrel and aspirin in prevention of ischemic stroke events. Of course, we are testing new drugs like ibrutinib or glucosamine, which are some clinical trials on supportive drugs like colchicine or inhibitor of 11 factor of coagulation system, but may have a supportive role and they may increase the sufficiency of antiplatelet treatment. So it's all. Thank you for your attention and have a good webinar. Thank you very much.
Thank you, Dr. Adam. It was a nice presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presentation and presence. So moving on to our next presenter. Thank you. So moving on to our next presentation, it is from Dr. Huing Wang from Peking University, Shuanggang Hospital, China. Hello, Dr. Huing Fang. Are you ready with your presentation?
Yes, I'm here.
Okay, I'm going to make you the presenter now. Yes. Now you can click on the button screen.
It's okay?
No, it's not visible to us.
You cannot see my press.
No.
No.
Please click on the screen button. At the bottom of your screen, you will be having a third button that is screen. Did you find that?
Yes.
Please click on that. If it needs permission on your system, what happened? What is it is asking like?
I can share the screen. Yeah. I
Like
don't
what
know.
is it showing there? What is it showing there?
I click it, but it doesn't work.
Okay, so if that's the problem, then you can do one thing. Please share your presentation with us. I will play and I will share my screen so that you can explain from there. Is it okay for you?
So how can I?
Please send your presentation to Miss Clara McBroom. I will take the presentation from her. and share my screen. Please make your presentation to her.
就是这个不行，这个传不上去桌面。I can send to you my PPT
Yes.
by email or
Yes, you
by email. Okay.
by email. Please send to Clara McBroom.
哇，可能有点不一样了，先是在这上面，在这个上，试一下。启动，推进一下。Yes, the email is sent.
Just allow
Yes.
me few minutes.
Yeah, you can check your. Perhaps I can. Okay. I can restart my computer.
Yes, you can do in that meanwhile.
Okay, so I'm so sorry. I was opening another account to try to let me be the speaker. Regina. Yes, this is okay.
Yes, yes. Now it's visible. You can start your presentation.
Yeah. I'm so sorry. There's a little problem with my computer.
Okay, no problem.
Hello, everybody. It's my honor here to report a case. An overfused middle cerebral artery anomaly. I can't change. Oh,
Please scroll over your mouse. It will get changed.
I can't change to the next.
Yes.
Okay. This is a 59 years old male. He was hospitalized on September 4th, 2017, with a history of paroxysmal slurred speech and left side headache for a week, with no other neurological symptoms. He had no remarkable personal history, and family history. When admitted, his blood pressure was 160/80, mild incomplete motor aphasia, no other neurological deficits. His outpatient had CT. Here, we can see his left MCA enlarged, and here has abnormal tortuous and dilated vessels. Also, nodulous calcification here. And also, in the parietal lobe, also had tortuous and dilated vessels and multiple punctate calcification here and here. His blood tests showed no abnormalities in lipids, blood glucose, and homocysteine. No significant abnormalities in electrocardiogram, echocardiograph, abdominal B ultrasound, and electroencephalogram. Had MRI presented that the distal branch of the left MCA was enlarged. There were tortuous blood vessels in the sulcus of the left temporal and parietal lobe, with no other abnormalities such as cerebral infarction or atrophy. His head and leg CT angiography angiosynthesis also showed calcification here at the same position of the head CT scan. Calcification also here, yes, but the vessels are not enhanced. We can also clearly see, the calcification is in the wall of the vessel, but not in the cavity. CT with a curved planar reformation, AP view, and the lateral view, showing that the left MCA is huge and tortuous, and almost the same diameter from the beginning to the end. CTA with a 3D reconstruction showing that the left MCA is huge and tortuous. From this picture, you can see a branch rising from the M1 segment and another small one here rising from the M2 segment. From these two images can more clearly show the huge and tortuous is very, very tortuous here. More clearly showed us the left MCA is tortuous and huge. So his right MCA is normal. DSA can show the huge left MCA and the tortuous. From the early arterial phase, we can see multiple striate arteries at the proximal segment of M1 and a branch rising from the distal segment of M1. Also, another branch rising from the segment 2, not M2. And from the arterial phase, capillary phase has low vein or abnormal vascular mass. This is the lateral view of DSA. From these three pictures, this is AP view. From these pictures, we can see the left MCA is huge and tortuous. It can be seen in capillary phase, vein phase, and also sinus phase. At first, the patient was treated as ischemic stroke. After the investigation finished, no special treatment was given on the patient anymore, but controlling his blood pressure to no higher than 130 and 80. The patient's speech impairment was relieved shortly after hospitalization, and at the same cured his left headache. The left headache developed again about 1 year later and was relieved quickly by lowering his blood pressure. In the later 2 years, there was no left headache, no speech impairment, or other symptoms. This is the schematic representation of the information of ICA, ACA, and MCA. It tells us that the MCA develops from multiple plexiform arterial tracts. MCA anomaly is not so common. Up to now, there are 5 kinds of MCA anomalies. They are accessory MCA, like here, this is accessory MCA, and also this one. Duplicated MCA, this picture, like this picture, also this one. duplicated origin of MCA, like this, two origin, and also this one. Fenestrated MCA, here is a fenestration, and also here there is a fenestration. Unfused or a plastic or twig-like MCA. This anomaly is reported in 2015. In this anomaly, there is no MCA trunk, but primitive arterial twigs. Like in this picture, no MCA trunk, but twigs. Also this one here. MCA develops from multiple plexiform arterial twigs by fusion and regression. All the above anomalies of MCA occur at the proximal segment of MCA and were hypothesized due to the failure in fusion of the primitive arteries. We hypothesized that the multiple plexiform arterial twigs fused excessively. The huge MCA formed as in our case, so we gave it the term overfused MCA. The anomaly in our case needs to be differential diagnosed with AVMs and AVFs. The primordial vascular channels failed to differentiate into mature intervening capillaries and veins, just like here, and instead create arterial venous shunts without intervening capillaries. AVM anatomy is essentially composed of one or more feeding arteries, a nidus, and one or more draining veins. The nidus connects to numerous vascular channels and is a high flow system where arterial blood shunting occurs. No capillaries, abnormal short circulating channels instead between the feeding artery and the draining vein of AVF. Where AVF differs from AVM is that AVF lacks a true nidus. The characters of AVM and AVF are arterial venous shunt, high flow arterial blood shunting, and abnormal drainage. Their critical character is that vein appears in arterial phase in DSA. Here is AVF. It can be seen from the patient's DSA that there is no vein or abnormal vascular mass in the artery and the capillary stage. That's to say there is no arterial venous shunt. PSA also showed that the left MCA's outflow is relatively slow, which may be because of the MCA's large lumen and large blood volume and normal vein drainage, demonstrating no high flow arterial blood shunting. There is an overfused MCA trunk in the patient, but there is no arterial venous short circuit, no high flow arterial blood shunting or abnormal vein. Therefore, AVM or AVF is not considered, and only a variation of artery is considered. The thrombotic AVM should be in consideration in this case because that the calcified vessels in the posterior side of the temporal and parietal lobe in head CT are not enhanced in CTA. 3 points that do not support this diagnosis. Firstly, the patient's DSA examination shows low thrombosis in the vessels and also can exclude AVM. Laterally, can exclude thrombotic AVM. The calcifications are located in the vascular wall rather than in the vascular cavity. Just like in this picture. It's in the wall, not in the cavity. Third, the DSA showed that the blood flow of the huge left MCA is slow, and the blood flow with enhancement agent has not reached the distal vessels during CTA scanning, which may be the reason why the vessels are not enhanced. No CT perfusion or MR perfusion was carried out on the patient, but on the one hand, the patient's MRI didn't show any cerebral atrophy, which may imply long period no perfusion. And on the other hand, the CTA and DSA showed only 2 distal branches from the huge MCA, which intimates overperfusion nearly impossible. So we conjecture that the anomaly in this case has not been affecting the ipsilateral blood supply. When blood pressure increases, local headache may be caused by vasodilation and traction, and also may caused by irritation of some factors such as serotonin. And paroxysmal reversible focal neurological disorder, such as speech impairment, may occur due to the local occupying effect. The drainage vessel is normal, but because the instantaneous blood perfusion exceeds the outflow, blood stasis appears at the end of the vessel, which may cause damage to the local vessel wall, such as calcification of the vessel wall. In one word, this anomaly has not brought serious and permanent damage to the patient. It is clear that there is no need to give special treatment to this patient at present. By controlling blood pressure, we can reduce the blood volume, decrease the tension to the vessel wall, and the blood stasis at the terminal vessel, so as to minimize symptoms and other bad consequences. In conclusion, we present a case with unique anomaly of MCA. The anomaly, which we termed overfused MCA, may form because of the overfusion of the embryonic arterial network. No serious and permanent symptoms and signs. No special treatment is required to the anomaly at present, but more observation to this case are needed, for it's followed only for about 3 years. That's all. Thank you for your attention.
Thank you, Dr. Huim Pang, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presence and your presentation. So our next presenter is Dr. Zi Zhang from Zunio Medical University, China. Hello, Dr. Zi Zhang. Are you ready with your presentation?
Hello. Can you hear me?
Hello.
Can you hear me?
Yes, you can. Yes. I'm going to make you the presenter now.
Yeah.
Yes.
Sure.
Now you are the presenter. You can share your screen with us.
Okay.
Yes, it's visible now.
Okay.
Yes, perfect.
Is my screen visible? Yeah.
Yes.
Okay. Hello, everyone. I'm Zheng Jie. I'm an associate professor in Zunyi Medical University in China. It's my pleasure to share my recent work with you here. My topic today is about how tau pathology impairs hippocampal neurogenesis in Alzheimer's disease. The underlying mechanism many involves the disruption of GABAergic transmission. It is now well established that Alzheimer's disease, here AD, is characterized by the neurodegeneration in the brain. By neurodegeneration, I mean the progressive loss of neuronal structure and function in the brain, namely the loss of synaptic connections, neurons, and possibly some other kind of cells such as oligodendrocytes. As a result, the brain atrophy can be generally observed in the brain of Alzheimer's disease patient. To date, the mechanism underlying the neurodegeneration is unknown. There are two popular hypotheses, including the A-beta and the tau. Many people think that the neurodegeneration in AD is attributed to the extracellular deposition of amyloid protein A-beta and the intracellular accumulation of hyperphosphorylated tau in neurons. But it is a challenge. To date, a large number of money and efforts has been devoted to the invested on the development of drugs against A-beta and tau. It is a challenge to repopulate the neurons in the AD brain, because the majority of neurons in our brain, especially in those of adults' brain, neurons cannot regenerate. So we wonder if there are some other ways to repopulate the neurons to rescue the neurodegeneration. A promising way to repopulate neurons in AD brains is to introduce neurogenesis in AD brains. To introduce neurogenesis, I mean there are many ways. For example, we can induce facilitating the innate hippocampal neurogenesis, or transplanting stem cells or intermediate progenitors into brain, or we can also reprogramming astrocytes in vivo to neurons. However, in my view, to introduce neurogenesis in the AD brain is quite challenging. The AD brain can be comparative to a field of poor soil in the desert. Neural stem cell can hardly grow, can hardly proliferate, and then differentiate into neurons, just like a little plant can hardly survive and thrive in the desert. In my lab, we mainly focus on the aggregation of phosphorylated tau protein, one of the two major pathologic changes in the eddy brain. We are wondering whether the aggregation of phosphorylated tau in the eddy brain can prevent or facilitate the process of neurogenesis. Actually, tau protein has been reported that tau protein plays an essential role in the experience like chronic stress or environmental enrichment. Tau protein is important in this experience-dependent regulation of neurogenesis. It is well known that stress can inhibit neurogenesis, and environmental enrichment can facilitate neurogenesis under normal conditions or under chronic disease. But when tau protein is knocked out, these two experiences cannot affect neurogenesis anymore. So this indicates that tau protein is important in neurogenesis. But our question is whether the accumulation of phosphorylated tau protein can affect neurogenesis in the eddy brain. Here, we mainly focus on the adult hippocampal neurogenesis, I mean the innate neurogenesis in our brain. We start to investigate the hypothesis. We start on this kind of neurogenesis because we believe it is quite stable and accessible model of studying neurogenesis, and we think it can mimic what happens in our brain better compared with in vitro models. So we focus on this. Firstly, we try to figure out the distribution of phosphorylated tau protein in the brain in the neurogenic niche of AD patient or animals. We find that the tau protein, the phosphorylated tau protein, I mean p-tau, is prominently distributed in the hippocampus, especially in the subgranular cell zone in the dentagerous subset. And furthermore, we found the p-tau is mainly colocalized with GAD76, which indicates that the p-tau is accumulated in GABAergic interneurons, both in the brain of AD patient and triple transgenic AD animals, AD mice. Only a small part, about 27% p-tau was accumulated in non-GABAergic interneurons, mainly the glutamatergic or excitatory neurons. So we next to investigate how p-tau accumulation will determine the fate of neurogenesis, we overexpressed human tau to mimic the abnormal accumulation of p-tau selectively in different subpopulations of neurons in the DG of mice, including the GABAergic interneurons, including the PV or SST positive interneurons, and the glutamatergic, the excitatory neurons, and the stem cell or progenitor cells in the DG. Simultaneously, we also used BRDU, DCX double coding for Node1 and retrovirus vectors to label the cell proliferation, the early survival, and maturation of newborn neurons in the process of neurogenesis, respectively. So we can evaluate how neurogenesis changed in accordance with the overexpression of human tau. We found that when we overexpress human tau in pan-GABAergic interneurons in the DG, the BRDU or DCX or Node1 positive cells were decreased, which indicates that the overexpression of human tau had inhibited the neurogenesis. It's the number of newborn cells decreased. Also, we used the retrovirus, the GFP expressed retrovirus to label the newborn neurons. We found that when the human tau is overexpressed, the total dendrite length and its complexity or the density of dendritic spines also decreased. So H-tau overexpression inspired the neurogenesis. Furthermore, we found that the H-tau overexpression had significantly increased the rate of morphologically atypical neurostem cells, which means H-tau, the accumulation of phosphorylated tau protein, has changed the shape or the function of neurostem cells. To prove that, we found that some the expression of some important genes in determining the neurogenesis have been reduced, downregulated by H-tau, but the genes facilitating the process of astrogliosis have increased. So we think that the accumulation of p-tau might inhibit neurogenesis, but facilitated the stem cells derived astrogliosis. To prove that, we delayed the injection of retrovirus, prolonged the expression of human tau, that we can trace the fate, the differentiation of the NSCs, the stem cells derived daughter cells. We finally found that the new cells eventually differentiated into the shape like astrogliosis, and it can localized with GFAP, a marker of astrocytes. Besides, we also, because we have found that the phospho-tau also accumulate in excitatory neurons and improve in intermediate progenitors. So we also tested how human tau overexpression in those cells will affect the neurogenesis. But we found human tau overexpression in both excitatory neurons and intermediate progenitors both show limited effect on neurogenesis. So we next focused on how tau accumulation in GABAergic interneurons will change neurogenesis. We used a fluorescent sensor of GABA to test whether and how the overexpression of human tau in GABAergic neurons will change the GABA responses. We found that human tau accumulation significantly inhibit the GABA responses. Furthermore, we found that the local level of GABA was downregulated by p-tau, by human tau. And we believe that this reduction of GABA can be attributed to the dysfunction, the change of phosphorylation level of GAD67, one of the two key enzymes responsible for the synthesis of GABA. And we also found that the human tau overexpression had downregulated the level expression of delta subunit containing GABA-A receptor. In accordance with the reduction of GABA, we found that the human tau also had the human tau accumulation resulted in the loss of inhibition of local excitatory neurons. The local neural network showed hyperactivity after following the overexpression of human tau. This was further proved by the increased Carson responses recorded by the GCAMP sensor. This shows that as we can see, the activity of glutamatergic neurons significantly increased in the group of human tau overexpression in interneurons compared with arbitrary controls. So we wonder if we use like threads, the HM4DI in combination with CNO to inhibit the overactivation of local excitatory neurons, whether we can rescue the H-tau-induced neurogenesis impairment. We found that the chemogenetic inhibition of local excitatory neurons can partly reduce the risk of the neurogenesis impairment as the number of newborn neurons significantly increased. But the stem cell derived neurostem cell derived astrogliosis was not affected by the inhibition of excitatory neurons. So we next used selective agonist of delta subunit containing GABA-A receptor, because we found this kind of GABA-A receptor was downregulated by the accumulation of phospho-tau. So we used its agonist to enhance the GABAergic signaling in local neural network. We found that the THIP can significantly increase the rate of typical neural stem cells and increase the BRTU or D6 labeled newborn neurons, and the dendritic maturation can be also improved by THIP. So strengthening GABAergic signaling by THIP can ameliorate the human tau accumulation induced neurogenesis impairment. Most importantly, we found that the THIP is also effective in promoting neurogenesis in the 6-month-old triple transgenic AD mice, which means that this drug THIP, enhancer of GABAergic signaling, may be effective in ameliorating the neurogenesis deficit in AD. And it can also improve the cognitive functions of AD mice, including the object place recognition and the contextual pattern separation. To sum up, we found that the accumulation of phospho-tau in the GABAergic interneurons can lead to the dysfunction of GAD67, and which causes the reduction of GABA in local network, which further can directly act on neural stem cells, or indirectly lead to the disinhibition of excitatory neurons, both of which can finally result in the reduction of neurogenesis and will facilitate the stem cells derived astrogliosis. As for the future work, we're investigating whether THIP can be used as a pro-neurogenic agent for the treatment of AD. And we recently developed a peptide chimera which can selectively dephosphorylate tau and facilitate its degradation. We're wondering whether directly reducing p-tau in the AD brain using this chimera can rescue the neurogenesis in AD brains. This part of work is mainly finished in Professor Wang Jianzhi's lab in Huazhong University of Science and Technology. We also would also like to show gratitude to Professor Wan You, Dr. Ma Longyu, Guan Rui, Yue Lupeng, Professor Yang Zhenggang, and Ma Cao for their help in this project. And I'm now working in the key laboratory of Zhonyi Medical University in the Guizhou province of China. It is a very beautiful and promising place. So if you are interested in my work, welcome to visit my university. And thank you for your attention. Thank you.
Thank you, Dr. Zi Zhang, for your presentation. Is anyone having any questions? Okay, no questions from anyone.
Okay.
Thank you once again for your presence and presentation.
Thank you. Thank you for your invitation.
Yes. So moving on to our next presentation, it is from Dr. Slawomir Manzwak from University of Lublin, Poland. But due to some reasons, he cannot able to present. So I will be sharing his video presentation. Now I will be sharing my screen. For just confirmation, do you able to see my screen?
Yes, we can.
Yes. Yes.
And is it audible to everyone?
Yes, I can see the video.
Okay.
At the beginning, I would like to focus your attention.
And what about audio? Is it audible to everyone?
Yes.
Okay, so I'm going to play the video now.
Thank you.
Mr. Chairman, for giving me the floor. I'm sorry I cannot take part live. At the beginning, I would like to focus your attention on neuropsychiatric symptoms as an early diagnostic manifestation of tumor. This is a case report. Let me briefly characterize neuropsychiatric symptoms. This is a heterogeneous group of symptoms, usually triggered by immune response against the tumor, not directly related with coexisting cancer or the local presence of cancer cells. It is very rare. Latest large-scale population-based study from Europe approximated the incidence of NPS to below 1 in 100,000 person years. It represents clinical rate of clinical manifestation. Neurologically, detection of particular antineural antibodies strongly supports or confirms the diagnosis. One may say antibodies serve as a marker. Here an example of neurological paraneoplastic syndromes from limbic encephalitis and cerebellar degeneration up to more complex such as diffuse encephalomyelitis. Let me shortly characterize limbic encephalitis. It is a cerebellar degeneration which is associated with malignancies such as small cell lung cancer and sometimes from time to the germ cell tumor as well. The antibody detected in the serum anti-HU and MA2, and the clinical characterization is quite different than others. So it starts from memory impairment, seizure, with changes of behavior and anxiety, with different level of depression. What is characteristic that develops also into pancreatic brain dysfunction, usually within weeks, but sometimes it can happen faster. At first, inflammatory process can be detected from analysis of CSF. However, at the beginning, neuroimaging remains silent. At the late neuroimaging studies reveal signs of extensive cerebellar atrophy, and after months or years or the first onset of disease. Here we have for the complication, potential complication, antibodies by binding to protein expressed by Purkinje cells lead to the Purkinje cells degradation, and by the dysfunction of pancreatic brain system, we finally observed an extensive cerebellar atrophy. And another example of neurological paraneoplastic syndrome, NMDAR, particularly observed among young women with the development of teratoma. When it comes to the related antibodies, commonly detected anti-N-methylene aspartate receptor. And here we have quite different panel of neuropsychiatric symptoms. It's commonly observed changes of behavioral changes with the memory impairment, with speech disorders, and finally seizures and disturbance of the consciousness. In the part 2, I would present a patient profile of 22 years old female admitted to the neurological department of Medical University in Lublin in April 2019 due to the various complaints. She had started complaining about constant headaches for more than 2 months before admission to the hospital. She impaired visual acuity, demonstrated the disturbances of the concentration and memory deficiencies. However, during short stay at ICU for the establishment of the primary diagnosis and excessive thirst or compulsive intake of fluids were observed. And at the time, patient drank more than 4 liters of water emptying a water dispenser. Coming back to medical history, family members also noted changes in personality and mood. She was confused, anxious, with a little delusional. 2 months prior to admission, a viral infection of the upper respiratory tract was noted. She was at the age 18 when we observed the first one set of PNS, and she's a mother of the one child at the age of 6. But the pregnancy was without any complication. She was not addicted to the nicotine, and she did not abuse alcohol and drugs. She has never smoked. No mental disorders were observed in the family. On admission, neuropsychiatric symptoms were observed, such as anxious. She was agitated, with slowness of mental processes. She was deeply confused, with deficient attention and logical thinking and learning, with disturbance with fresh and late memory, and with tendency to confabulation. The results of neurological examination did not find any abnormalities. Also, CT scan results did not show any characteristic findings. The decision was made to admit patients to the neurological department, and then we have started to hypothesize to establish the final diagnosis. Taking into account the one set of headache, constantly headache for more than 4 weeks, we thought about stroke, meningitis. However, polydipsia also, as it's not a common syndrome, so we thought about the first one set of schizophrenia or about the diabetes. However, during hospitalization, 2 spells of seizure were noted, and bulimia symptoms also occurred. So finally, an instructive results was based upon the interpretation of the MRI diffusion DWI imaging sequence, which showed bilateral diffusion limitation in the caudal head, thalamus, and cortical layer of the right temporal lobe. Here we observed MRI results, also localized in cortical and subcortical zone, and EEG also was performed. However, we did not find any specific findings except of slowing down polymorphic delta and alpha activity predominantly in the frontal parietal part of brain. The diagnostic testing was not characteristic. Cancer markers such as CA125, serum neuroonconal antibodies, serum anti-NMDA were negative. The decreased level of serum sodium was probably due to the recognition of the excessive dehydration. And finally, the elevation level of serum anti-GAD antibodies at the level more than 250 international units in cooperation or with the interpretation of the medical history and clinical findings led us to establish final diagnosis autoimmune limbic encephalitis. Moreover, the general picture and composition of CSF was good without any clinical findings, apart from the elevation level, slight elevation level of protein up to 6-7 milligrams per deciliter. Okay, at the time we thought about next steps, and there were some questions given to issue an answer. So, was it reasonable to suspect a cancer, and if so, what kind of cancer could be considered? The next step, we performed USG of the abdominal cavity and pelvis. An abnormal mass of the left ovary was identified. PT scan showed increased metabolism within the left ovary. So we have started immediately corticosteroid-based therapy, starting from 1 gram per day for 3 days, in associating with intravenous immunoglobulin given at the dose 400 milligram per day for 4 days. Also, anti-epileptic drugs were recommended. And however, no clear clinical improvement was noted, apart from the cessation of seizure events. Patient was transferred to gynecological department to undergo radical surgical treatment. It was done without any complication, and the final pathomorphological examination revealed the recognition of unnatural G3 teratoma. It should be also emphasized that the patient underwent 5 courses of plasmapheresis. However, we have observed only weak neuropsychiatric improvement, with cognitive processes remain disturbed. And finally, the patient was transferred to the oncological department for complementary chemotherapy. According to BEP scan, we recommended 3 courses. And the first day, 1 course was completed with good tolerance of treatment. The patient was discharged home. However, in a couple of days, this time in emergency procedure, she was readmitted with the exacerbation of symptom infection, development of 3rd-degree neutropenia associated with neutropenic fever. And we have started granulocyte colony stimulating factor and the antibiotic therapy, empiric antibiotic therapy also was given with resumed steroid pulses as well. After improvement in hematological parameters and the final psychological consultation, the 3rd and the 2nd scheme courses was done with reduced doses up to 80% in association with supportive drug. However, both courses were completed successfully. The final CT scan interpretation to assess the effects of chemotherapy. It was thoracic, abdominal, and small pelvis CT examination in 2.5 millimeters layers with 3 phase shading agents. No target changes were observed. Here I have 2 slides describing the encephalitis regression during treatment. And finally, I would focus your attention on discussion. Autoimmune encephalitis results as a dysfunction of the different brain structure due to the production of antibodies against specific neuron antigens. An appropriate immune response triggered by a viral infection coexisting of malignant neoplasm or without any underlying pathology. In the case presented, the response had probably been triggered by the viral infection. Symptoms of CNS may include seizures and subacute changes in the level of consciousness, behavior, cognitive function, or autonomic dysfunction, heart arrhythmia, instability of blood pressure, and fever. In the case presented a while ago, a wide variety of neuropsychiatric manifestations were noticed. The most common antibodies found in patients with are N-methyl-D-aspartic acid receptor antibody, leucine-rich inactivated with galloma, voltage-dependent potassium channel, contact protein 2-like antibodies, anti-gamma aminobutyric acid receptor, and finally anti-alpha amino 3-hydroxymethyl isoxylopropionic receptor. It's a very difficult. Teratomas are embryonic tumor composed of many types of cells from one or more 3 germ layers. They range from mild, well-differentiated, mature, cystic changes to those that are solid and malignant immature. Malignant transformation occurs in 1 to 3% of mature cystic teratomas, usually in postmenopausal women. In the discussed case, anti-GAT was the only AB detected in the patient serum. Non-cancer markers like CA125 were detected. Early diagnosis and successful treatment of teratoma was possible exceptionally due to neuropsychiatric manifestation of IPS. The tumor could also be detected ultrasonically, but the patient was not at increased risk, was young, just after pregnancy, and did not report any characteristic symptoms of ovarian cancer. Mature cystic teratoma may be early manifested by several neurological symptoms. Screening testing of antibodies related to the most common paraneoplasmatic syndromes may possibly want an effective utility for the reduction of advanced stage diagnosis percentage in some cancers, and therefore contribute to decreasing the high mortality. Thank you very much for your attention.
Thank you everyone for listening to the presentation of Dr. Salome. Now we can take a lunch break and we'll be back at 13:25. Please stay connected till then.
Okay, thank you.
Thank you.
I know, like you said,
Thank you everyone for staying connected. So now we will start our next session after the lunch. And the next session is presented by Dr. Concita Simone from University of Messina, Italy. Hello, Dr. Concita. Are you ready with your presentation?
Good afternoon. Yes.
Okay, so I'm going to make you the presenter now. Yes, it's done. Now you can share your screen with us and start your presentation. Yeah, it's visible now with us.
Okay. Good morning. I would like to thank you, the organizing committee, for giving me the opportunity to present my results about thrombin effects on CCM gene expression in human brain microvascular endothelial cells, and to discuss about the possible role of thrombin in progression of cerebral cavernous malformations. Cerebral cavernous malformations are vascular lesions affecting brain microvessels, and they appear as as lesions with a Melbury-like shape. They represent about the 10–20% of all cerebrovascular malformations, and in general population show an incidence ranging between 0.1 and 0.5%. The lesions are usually diagnosed by magnetic resonance imaging. We know that vessels affected by cerebral cavernous malformations are usually enlarged and tangled due to the reduced number of pericytes and due to the defective junction system. In particular, both tight junctions and other junctions are highly impaired. So this results in loss of properties of blood-brain barrier that is more permeable, leading to intracerebral hemorrhage and seizures that are the main symptoms of cerebral cavernous malformations. Other symptoms include headache and focal neurological deficits. About genetics, we know that cerebral cavernous malformation can arise sporadically or be inherited. The sporadic form of the disease usually has a late onset and usually is characterized by single lesions. However, were also reported sporadic patterns with multiple lesions. In contrast, the familial form of the disease usually has an early onset. Indeed, multiple lesions are already present at pediatric age, and it is inherited with an autosomal dominant pattern due to germline mutations at the three genes CRIT1, CCM2, and PDCD10. Features of the genetics of the familial cerebral cavernous malformations are the incomplete penetrance and the variable expressivity. The three CCM genes encode for three proteins that co-localize at adherent junctions between endothelial cells. This co-localization makes the formations of the CCM signaling complex. The three proteins indeed contribute to stabilization of vascular endothelial caderins at adherent junctions. However, each proteins also as a proper signaling pathway. In particular, CRIT1 is involved in the beta-integrin signaling transduction. CCM2 is a negative regulator of the P38 cascade signaling, while CCM3 is PDCD10 is a positive regulator of the apoptotic process. All these signalings contribute to the correct vasculogenesis during embryo age. From recent data, we know that about 7% and about 95% of familial and sporadic patients, respectively, show no mutations at the 3 CCM genes. So the aim of the study is the identification of further genetic factors involved in CCM pathogenesis. So we aimed to identification of dysregulated genes in CCM tissues. In particular, we performed the first expression analysis by whole RNA sequencing on endothelial cells separated from CCM biopsies. In detail, endothelial cells were separated by a MIDI-MAX separator system by using microbeads labeled with anti-CD31 antibodies and following enzymatic digestions of CCM biopsies removed by surgical intervention. In detail, we worked on 2 biopsies removed by 2 different young patients affected by sporadic form of the disease. The patients were tested for germline mutation and they resulted negative. Moreover, we used the human brain microvascular endothelial cells as a negative control, so as expression reference. First of all, we searched for somatic mutation in CCM-derived endothelial cells. In particular, by sanguine sequencing, we search point mutation, while by multiplex ligation dependent probe amplification, we searched for large genomic rearrangements. However, both the analysis resulted negative, and only 2 different polymorphism were identified in the CRIT1 gene. However, these polymorphisms are not linked to the disease onset. So we proceeded with RNA sequencing and by construction of paired end libraries that were sequenced on ANOVA 6000. Raw data were trimmed and low quality reads were removed. Filtered reads were mapped against the human reference genome JFCH38 and against the ensemble RNA database version 99. For downstream analysis, we and in particular for expression analysis, differential expression analysis, we applied the differential gene expression empirical analysis of differential gene expression statistical algorithm, and in particular we considered only genes showing a log2 change lower than -1 for down-expressed genes, and a log2 change upper than 1 for up-regulated genes. Gene annotation and categorization was performed according to the following databases. So, following differential gene expression analysis, we noticed that 2,798 and 5,414 coding genes resulted differentially expressed respectively in CCM-derived endothelial cells from the first and the second biopsies. In particular, of these regulated genes, 1,325 were common to the both samples. So we clustered these genes, and enrichment analysis allowed to cluster to highlight 80 terms that were related to neuroinflammation, vasculogenesis, response to oxidative damage, extracellular matrix remodeling, and cell junction impairment. However, we noticed that a particular pathway was also particularly enriched. In particular, the thrombin, the protease activator receptor pathway activated by the thrombin. So we decided to focus on this pathway. Protease activator receptors are a family of receptors belonging to the 7 transmembrane domain G protein coupled receptor family. And these are 4 members, part 1, part 2, part 3, and part 4. And the particular these receptors are characteristics because they are activated following a proteolytic cleavage by proteases, and in particular by thrombin. In endothelial cells, in particular in endothelial cells of the blood-brain barrier, part 1 is highly represented, and its hyperactivations lead to the loss of blood-brain barrier properties with an increased permeability of endothelial cells. So, first of all, we proceeded with quantification of protease activated receptors genes by expression by real-time PCR in our CCM-derived endothelial cells. And we noticed that in particular, part 1 is highly expressed in our samples when compared to the control one. No differences were observed in expression level of thrombin and SLAT1. So we decided to expose human brain microvascular endothelial cells to low thrombin concentrations, and in order to test how, if and how expression of CCM genes was perturbed. So we treated human brain microvascular endothelial cells with 0.1 units per ml of thrombin at different time points. And what we noticed was that CRIT1 expression increased following 3 hours of thrombin treatment. And this level, however, decreased over the time. In contrast, CCM2 expression decreased following up to 6 hours of treatment. However, PDCD10 expression has had a different trend because its expression increased up to 6 hours. So, in endothelial cells, it was shown that thrombin impairs cell junctions via PAR1, in particular because activation of this receptor leads to down expression of zonular occludens 1 protein, of the increase the phosphorylation of vascular endothelial cadherin, and reduces the polymerization of actin. Moreover, thrombin induced was shown to induce apoptosis. So, about the CRIT1 expression following its peak of expression after 3 hours of the thrombin treatment, the following down expression probably can contribute to the disruption of the endothelial junctions, as well as the increased expression of PDCD10 can contribute to the shift toward apoptotic pathway. However, the more interesting data is about CCM2, because CCM2 is a negative regulator of the P38 and the MAC3 cascade signaling. Indeed, MAC3 signaling activation leads to vascular remodeling, cell migration during angiogenesis. As we observed, following thrombin treatment, CCM2 expression decreases. So this results in an missing negative regulation of this pathway that therefore was amplified, leading to CCM, probably leading to CCM formation. So, we think that this mechanism is requires further investigations. So, in conclusions, we started by a characterization of expression profile in CCM-derived endothelial cells, and we noticed a perturbation of the protease activator receptors pathway. This, so we proceeded by evaluating expression of PARs in our pathological cells, and noticed that all protease activator receptors genes are overexpressed. And finally, we identified that CCM gene expressions changes following thrombin exposure in human brain microvascular endothelial cells. So we think to proceed with our study, and in particular we proceed in order to find a link between protease activator receptor signaling activation and CCM development. And we think that the MEC3 and in particular the MAP kinases cascade can be a valid link for future investigations. So thank you to all my lab members, in particular Professor Antonina Sidoti and Rosalia D'Angelo, and my colleagues Dr. Carmela Rinaldi, Luigi Donato, and Simona Librandi. And I would like to thank you also, Prof. Concetta Lafaci, for the CCM biopsies, and thank you everybody for attention.
Thank you, Dr. Concetta, for your presentation. Is anyone having any questions? Okay, I think there are no questions. Thank you once again for your presence and your presentation.
Okay, thank you. Bye.
So moving on to our next presentation, it is from Dr. Eugenio Cavalli from University of Catania, Italy. Hello, Dr. Eugenio. Are you ready with your presentation?
Yeah.
Yes, I'm going to make you the presenter. Yeah, it's done. Please share your screen with us and start your presentation. Now it's visible to us.
Okay, it's visible?
Yes.
Okay. Good afternoon, everyone. I'm Eugenio Cavalli. I'm a researcher for University of Catania. During my working period for IRCCS Bonino Puleio in Messina, is an hospital and a research center for neurodegenerative disease, I performed a study regarding to an in vitro model of amyotrophic lateral sclerosis to test two non-psychotropic cannabinoids and their capacity to counteract the neuroinflammation. The motoneuron-like cell line NSC34, differentiated by serum deprivation and with additional treatment of all trans-retinoic acid, is a valid model to investigate molecular events linked to neurodegeneration and neuroinflammation in amyotrophic lateral sclerosis. Neuroinflammation is defined as an inflammatory response within the brain or spinal cord. This inflammation is mediated by the production of cytokines, chemokines, and reactive oxygen species, and secondary messengers. These mediators are produced by resilient CNS glia, like microglia and astrocytes, endothelial cells, and peripheral derived immune cells. There are immune, physiological, biochemical, and psychological consequences of the neuroinflammation response. Moreover, the degree of neuroinflammation depends on the context, duration, and course of the primary stimulus or insult. Chronic and uncontrolled inflammation is characterized by increased production of cytokines, IL-1 and TNF, for example, or reactive oxygen species, or other inflammatory mediators. These markers are highly evident following trauma to the CNS and are accompanied by significant recruitment and trafficking of peripheral macrophage and neutrophils to the site of injury. The transient inflammation after repeated social defeat stress also leads to monocytes and macrophage recruitment and cause anxiety and depression. Microglia are the focal point for any discussion of neuroinflammation. This because the innate immune cells perform the primary immune surveillance and macrophage-like activities of the CNS, including the production of cytokines and chemokines. Indeed, much of the innate immune capacity of the CNS is mediated by microglia. These cells are resident CNS cells that reside in both the white matter and gray matter of the brain and spinal cord. Overall, microglia comprise 10% of the CNS population. Microglia develop early in embryogenesis from amyloid precursor cells in the embryonic yolk sac and migrated to the area of the CNS around embryonic day. In fact, microglia have the same progenitor as the rest of the long-lived tissue macrophage of the body. Consistent with this idea, microglia are long-lived cells that have limited turnover from the myeloid cells of the bone marrow during the course of a lifetime. So these cells are not replaced from myeloid cells of the bone marrow. Nonetheless, when depleted, microglia turnover is possible from a potential progenitor source within the CNS. Microglia, during the progression of amyotrophic lateral sclerosis, neuroinflammation is part of the pathophysiology in ALS. It is induced by activated microglia, astrocytes, and infiltrating CD4 and CD8 T lymphocytes, and has been considered a secondary unspecific reaction to the degeneration of the motor neurons. Several studies have found that microglia pathology correlates with disease progression. However, recent finding indicates that the neuroinflammation may in fact be a primary event with results from a detrimental interaction between the degenerating motor neurons and surrounding cells. Thus, synaptic pruning mechanisms governed or at least influenced by complement mediator as specified above may be inappropriately reactivated in the aging braining and thereby contribute to or even cause the progression of Lovos synapses in amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis was first named by the French neurologist and anatomist Jean-Martin Charcot, who described the clinical pathology of the disease. Amyotrophic refers to the atrophy of the muscles. Lateral refers to the failure of the Schending fibers in the lateral column of the spinal cord, and the sclerosis in the hardening of the structure of the suppurative tissue surrounding motor neurons. The progressive loss of both upper and lower motor neurons leads to the loss control of skeletal muscle with muscular atrophy, hypereflexia, fasciculations, and eventually paresis of both bulbar and extremity muscles. Amyotrophic lateral sclerosis is, we know, is a rare and devastating neurodegenerative disease with a poor prognosis, indicated by a median survival time of 36 months from onset of the disease. Even so, the clinical pathological findings have been known for almost 2 centuries. The etiology of amyotrophic lateral sclerosis remains unknown, and no effective treatment exists. However, resident evidence points toward the innate immune system, and in particular the complement system as a potential culprit and hence a future target for treatment. Numerous different factors have been suggested to contribute to the pathogenesis of ALS, including aggregation of misfolded protein, impaired clearance of XG toxins such as glutamate, or mitochondrial dysfunction, oxidative stress, malfunction of the endoplasmatic reticulum,
impaired axonal transportation mechanism, and dysregulation of intracellular calcium levels, and detrimental environmental factors, and neuroinflammatory reaction during the destruction of motor neurons. In recent years, many in vitro and in vivo studies have demonstrated the therapeutic potential of cannabinoids for the treatment of neuroinflammatory disorders due to their antioxidant and anti-inflammatory properties. Cannabis sativa is a plant for the Cannabinaceae family, widely utilized for its psychoactive and therapeutic effects. To date, more than 120 cannabinoids have been isolated and characterized. The most investigated cannabinoids are delta-9 tetrahydrocannabinol, cannabidiol, cannabigerol, cannabidivarin, but delta-9 THC is the predominant psychotropic component of the plant.
Yeah, hello, Dr. Iguena. I think there is some network issue with Dr. Eugenio Cavalli. We will wait for some time so that he will rejoin us and continue with his presentation. Please allow me 5 minutes. I'm going to contact Dr. Eugenio. Dr. Eugenio is having some network issues and he requested to wait some few minutes. Please support us. Okay, I think it will take time for him to join. So I would request Dr. Paolo Fagon to present his speech. Hello, Dr. Paolo. Are you ready with your presentation?
Hello, I'm ready. Can you hear me?
Okay. So I'm going to make you the presenter.
Thanks.
Yes, it's done. Now you can share your screen with us and start your presentation.
Thank you.
Yes, your screen is visible to us.
Okay, good afternoon, and thank you for inviting me. I'm going to talk about the involvement of tetraspanin 32 in cellular immune responses and in multiple sclerosis. We do believe that TSPAN 32 is a novel pathogenetic factor involved in the regulation of the immune responses. TSPAN 32 is a member of the tetraspanin family. The tetraspanin family comprises a series of proteins which share the common protein structure, which comprise 4 transmembrane domains, numbered from 1 to 4. And then we have a small extracellular loop, which is flanked by the transmembrane domain 1 and 2, and a large extracellular loop, which is flanked by transmembrane domain 3 and 4. In the intracellular compartment, we have both the N-terminus and C-terminus tails, and then we have the small intracellular loop, which is flanked by transmembrane domain 2 and 3. Tetraspanins are post-translational modified by glycosylation, and also we have the addition of several palmitate moieties, which allows the tetraspanin members to interact with each other. Tetraspanins are evolutionarily conserved. We can find them pretty much in all metazoans. In particular, in the human species, we have 33 different tetraspanins. Some of them are restricted to specific organs or tissues that are ubiquitous. They tend to interact with one another, and they form the so-called tetraspanin web and the so-called tetraspanin enriched domains. These interactions are dependent on the palmitate moieties in the juxtamembrane region, and also depend on the interaction with the gangliosides and membrane cholesterol. The tetraspanin are able to interact with a series of other proteins, including integrins, caderins, growth factors, immunoglobulin-like receptors, and are able to activate a series of intracellular signaling pathway, including protein kinase C. Also, they can activate the PI3K/AKT/mTOR pathway. They are able to activate the raw GTPases, for instance, RAW-A, RAC1, CDC42, which are very important for cell adhesion and also for cell motility. Also, tetraspanin are able to regulate the intracellular levels of beta-catenin. So there's quite a wide range of biological processes which are regulated by tetraspanins, and they are also involved in pathological processes, for instance, in cancer. And sometimes different members of the tetraspanin family have different roles. For instance, as regards metastatization, we can see that TSPAN9, for instance, is a pro-metastatic gene, while CD151 and TSPAN8 counteract the metastatic and mobility process of the cells. Tetraspanins are also involved in the regulation of immune responses. In this table, we can see a series of tetraspanins which are known to regulate cellular immunity. For instance, we have CD9, CD37, CD63, CD151, and then we have also highlighted in red TSSC6, which is a synonym for TSPAN32. TSPAN32 is mainly restricted to the hematopoietic system, so the highest levels of TSPAN32 can be found in the tonsil and the spleen in the lymph nodes. And the same data are expressed here as an atomogram of TISPAN32, which was retrieved from the human protein database. As we can see, TISPAN32 is mainly expressed in the vascular and lymphatic system, while the other organs have much lower levels of TISPAN32. And it's also interesting to note that TISPAN32 is mainly localized in the nucleoplasm, and there's also some positivity in this immunofluorescence image. There's also positivity for the localization of TISPAN32 in the endoplasmic reticulum. There are in the literature a few works, few papers regarding the role of TISPAN32 in the regulation of the immune responses. And one that I like to point out is this paper from 2002 and from the group of Tarrant, which showed that mice which are transgenic for TISPAN32, which bear null mutation in both copies, both alleles of TISPAN32, these mice show that they have a normal development of the hematopoietic system, but however, their T cells are hyperproliferative because they produce a higher level of interleukin-2. On the contrary, the B cells and immune responses of these mice seem to be quite normal. So, based on this data, we wanted to better characterize the role and expression of TISPAN32 in immune cells. So, first thing first, we determined the levels of TISPAN32 in the different immune cell populations. And as we can see here, we have much higher levels of TISPAN32 in the lymphoid lineage cells as compared to myeloid cells. And it is also interesting to note that the higher levels of TISPAN32 are in the parafollicular areas and co-localized with the expression of CD3, which is the marker for T cells. In the maturation of T cells, we can see that low levels of TISPAN32 can be observed in the early T cell precursors and in the double negative stage of T cell maturation, while there are higher levels of this gene at the stage of double positive cells and in the single positive naive T cells. Next, we wanted to determine whether TISPAN32 undergoes a modulation during the activation of T cells. So we looked at the expression levels of TISPAN32 in effector T cell upon stimulation at different time points with anti-CD3, anti-CD28 antibodies. And as we can see here, there's a time-dependent reduction in TISPAN32 levels, which reaches the significance at 5 and 6 hours. And also we noticed that it was sufficient stimulation with an anti-CD3 to determine downregulation of TISPAN32, and this effect was further potentiated when we added an anti-CD28, but not when we added an anti-CTLA4, anti-ICOS, and anti-PD-1 antibody. Since the engagement of the TCR and the activation of T cells is associated with an hyperactivation of the mTOR pathway, we also wanted to determine whether the inhibition of this pathway was able to regulate, to modulate the expression of TISPAN32. And as we can see in panel C, we show that rapamycin, which is a specific inhibitor of mTOR1, is able to determine upregulation of TISPAN32 as compared to stimulated cells with anti-CD3 and anti-CD28 antibodies. We also wanted to determine whether regulatory T cells had a similar response in terms of TISPAN32 expression upon restimulation. As we can see in panel D, there is actually a much milder response in regulatory T cells. Indeed, there is a mild downregulation of TISPAN32, which reaches a significance only at the 5-hour time point. Next, we wanted to characterize the expression levels of TIS-PAN32 in polarized cells, T cells, toward the Th1 and Th2 phenotype. Both Th1 and Th2 cells have lower levels of TIS-PAN32, and also it is interesting to note that Th1 cells have slightly lower levels of TIS-PAN32 as compared to Th2 cells. And this downregulation of TIS-PAN32 is peculiar for TIS-PAN32 and is not in common with the other tetraspanids that are commonly involved in the cellular immune responses. For instance, we can see here that CD37, CD63, CD82 are upregulated in Th1 and Th2 cells, on the contrary of TIS-PAN32. Our data were further confirmed by this data. Here we show the modulation of the transcription and translation of TIS-PAN32 upon restimulation in vitro of already polarized Th1 cells. As we can see in panel A, the de novo transcriptional levels of TIS-PAN32 undergo a downregulation of at least twofold as early as 1 hour upon Th1 cell restimulation. And accordingly, we have also a significantly lower level of translational rates of TIS-PAN32 as early as 30 minutes upon Th1 restimulation. And it is also interesting to note that there is a strong and negative correlation between the production of TIS-PAN32 and the expression of interferon gamma, which is a typical pro-inflammatory cytokine produced specifically by Th1 cells. Next, we determined the levels of TIS-PAN32 in memory T cells. As we can see here, memory T cells, even in the unactivated state, have lower basal levels of TIS-PAN32 as compared to naive T cells. And these cells, upon activation, undergoes a further downregulation of TIS-PAN32. So, basically, all of this data confirm the hypothesis that TIS-PAN32 is negatively associated with the immune activation of T cells, and is further supported by our phylogenetic analysis. As we can see in panel A, we observed that among the co-evolved genes with TIS-PAN32, we have PD-CD1, which is a synonym for PD-1. PD-1 is an inhibitory immune checkpoint which restrains the immune response of T cells. And so basically this data supports the notion that TIS-PAN32 and PD-1, although they have different protein structure, may have evolved during the evolution toward the same biological function, which is to function as a brake of the immune response. Based on these observations, we wanted to characterize the levels of TIS-PAN32 in multiple sclerosis. Multiple sclerosis is an autoimmune disorder which is characterized by type 4 hypersensitivity reactions directed towards oligodendrocytes and oligodendrocyte antigens, such as PLP, MOG, MBP. First, we looked at the levels of TIS-PAN32 in a mouse model of multiple sclerosis. As we can see here, encephalotogenic T cells isolated from the brain and spinal cord of mice immunized for multiple sclerosis, develop this model of multiple sclerosis, have lower levels of TIS-PAN32 as compared to naive T cells isolated from the spleen of the same mice. And when we looked at the circulating CD40 cell from multiple sclerosis patients, we observed that upon restimulation, CD40 cells from multiple sclerosis patients have significantly lower levels of TISPAN32 as compared to the cells from the healthy donors. Next, we investigated the expression of TISPAN32 in CCR6 memory T cells from HLA-DR4 positive healthy subjects and HLA-DR4 positive multiple sclerosis patients. And the cells were sorted based on the tetramer staining for MOG and PLP. Upon stimulation of these cells with PHA interleukin-2 MOG and PLP, we observed a significant downregulation of TISPAN32 in tetramer positive multiple sclerosis cells versus tetramer negative healthy donor cells. We also observed a downregulation of TISPAN32 in tetramer positive cells from healthy donors versus tetramer negative cells from healthy donors. And finally, we observed also a significant downregulation of TISPAN32 in tetramer negative cells from multiple sclerosis patients versus tetramer negative cells from healthy donors patients. So basically, these data support the notion that T cells from multiple sclerosis patients have a lower threshold of activation as determined by the lower level of TISPAN, and this is independent on the autoreactivity of the T cells. And indeed, by performing a hierarchical clustering of these cells based on their transcriptomic profile, we found that both tetramer positive and tetramer negative cells from the multiple sclerosis patients tend to cluster together more than they do with the corresponding cell populations from the healthy donors. We also identified all the genes that were co-regulated with TISPAN32. We found approximately 600 genes, and these genes were involved in several biological processes, such as GTPase-mediated signaling transduction, meiosis, and DNA repair. Finally, we wanted to investigate the diagnostic and prognostic role of TISPAN32 in multiple sclerosis. As we can see in panel A, the peripheral blood mononuclear cells from multiple sclerosis patients have significantly lower levels of TISPAN as compared to PBMC from healthy donors. However, there was no major difference in the cells from patients in stable disease and patients in relapsing disease. Next, we observe the prognostic role of TISPAN. Although these data are not significant, there is an interesting trend. Indeed, we can see that patients that have in their PBMC lower levels of TISPAN32 tend to have shorter periods of stable disease. So, in a way, TISPAN32 may also act as a prognostic factor to predict the relapse of the disease. To sum up, I would like just to say that TISPAN32 is a member of the tetraspine family, and it is involved in cell-mediated immune responses. And its behavior is completely different from other tetraspane, such as CD9 and CD63, which are involved in antigen presentation of the cell signaling. And in the tetraspane 32 is negatively modulated upon T cell activation. So basically, all of our data suggest an immunoregulatory role for TISPAN32, and we propose TISPAN32 as a novel inhibitory immune checkpoint. So our data represent a starting point for the ideation of possible novel therapies for immunoinflammatory and autoimmune disorders. And these are all, just a note, it's just a data on multiple sclerosis, and we have several other preliminary data on other autoimmune disorders, and in particular the rheumatoid arthritis, and more recently with the systemic lupus erythematosus. So this was my last slide. I would like to thank you all for your attention. I would like also to acknowledge all my colleagues and my mentor, Professor Ferdinando Nicoletti, Professor Katia Mangano, Dr. Basile and Dr. Cavalli. Thank you for your attention.
Thank you, Dr. Polo, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presence and your presentation.
Thank you.
Yeah. As we are left with our presenter, Dr. Eugenio Cavalli, so we will continue with their presentation. Hello, doctor.
Hello.
Are you ready? Yeah, are you ready with your presentation now?
Yeah.
Okay, I'm making you the presenter. Yes. Please share your screen with us. Yes.
So I start from the beginning, or can I continue?
You can continue from that.
Okay. So in recent years, many in vitro and in vivo studies have demonstrated the therapeutic potential of cannabinoids for the treatment of neuroinflammatory disorder due to their antioxidant and anti-inflammatory properties. Cannabis sativa is a plant of the Cannabinaceae family, widely utilized for its psychoactive and therapeutic effects. To date, more than 120 cannabinoids have been isolated and characterized. The most investigated are delta-9 tetroidocannabinol, cannabidiol, cannabigerol, cannabivarin, and cannabidivarin. Delta-9 THC is the predominant psychotropic component of the plant, and in the last year, CBG and CBD are the two non-psychoactive cannabinoids more studied due to their anti-inflammatory and antioxidant properties. The anti-inflammatory and antioxidant effect of CBD on movement disorder have also been proved in several preclinical and clinical studies. However, the beneficial effect in many of these studies have been observed when CBD is combined with the delta-9 THC. CBG and CBD exert their activity at multiple molecular sites. They may exert their actions by binding class AG protein coupled receptor, cannabinoid receptor type 1, this is the most abundant neuromodulatory receptor in the brain, and the cannabinoid receptor type 2. Cannabinoids could also activate the transient receptor potential vanilloid channel 1, and the serotonin receptor 5-HT1A, or modulate G protein coupled receptor. Their effect may also include interaction with the transcription factors, such as the nuclear factor NRF2 and the nuclear factor kappa, or a nuclear receptor of the peroxisome proliferator activator receptor PPAR family. CBG and CBD have demonstrated to exert neuroprotection by activation of the nuclear receptor of PPAR gamma by a mechanism cannabinoid receptor independent. Regarding to the study and material and methods, the extraction and isolation of CBG and CBD from cannabis sativa was provided by greenhouse cultivation at Criacin in Rovigo, Italy. And CBG and CBD were isolated and purified with 99% of purity, and according to the standardized protocol to avoid any trace of THC. The NSC34 motoneuron cell line were differentiated with 1 micromolar of all-trans retinoic acid, and after 5 days of treatment, the morphology was changed and became neuron-like cells with interconnected neuritis. The row 264.7 is a murine macrophage cell line, were incubated with 1 micrograms ml LPS from Escherichia coli for 24 hours for the production of the LPS stimulated medium. So after the cell differentiation, the culture medium of NSC34 cell was replaced with array free medium, so without retinoic acid, and treatment with different concentration of CBG at 2.5 and 5 micromolar, and CBD at 2.5 and 5 micromolar alone, and in a combination 1-1, and with the vehicle DMSO for 24 hours. After 24 hours, the medium was replaced with a culture medium from LPS stimulated row, and the cannabinoid treatments restored. The cells were incubated for a further 24 hours. So in differentiated NSC34 cell, we evaluated by an MTT assay the possible toxicity of motor neuron of serial concentration at 2.5, 5, 10, 20, 40, and 80 micromolar of CBG and CBD alone and in association. No significant variation of cell viability was observed at all those tested. And we also analyzed the NSC34 cell incubated with dimethyl sulfoxide, but not cytotoxicity was observed. This data not shown in the slide. We showed cytokine modulation, and motor neuron exposed to the LPS stimulated medium showed a significantly higher level of tumor necrosis factor compared to the unstimulated cell in figure A. CBG pretreatment at all those tested, both alone and in association with CBD, was able to significantly downregulate TNF alpha expression. On the contrary, the CBD result was less effective at 2.5 micromolar in figure A. As shown in figure B, NSC cells exposed for 24 hours to LPS stimulated medium expressed a significantly lower level of the anti-inflammatory cytokine IL-10 compared to unstimulated cell. Only the pretreatment with CBG 5 micromolar plus CBD 5 micromolar leads to an increase in basal levels of IL-10 cytokine in figure B. CBD, both alone and in association with CBG, was able to upregulate the anti-inflammatory expression cytokine IL-37 compared to the LPS group. This we can see in the figure C. The exposure of a differentiated NSC34 cell to the LPS stimulated medium inducing a significant degradation of cytoplasmatic IKB alpha, as well as significant NF-κB nuclear translocation compared to unstimulated cells. Only the association CBG 5 micromolar plus CBD 5 micromolar was able to inhibit NF-κB nuclear translocation correlated with high levels of cytoplasmatic IKB alpha. Instead, the association of CBD 2.5 micromolar plus CBD 2.5 micromolar was able to inhibit only NF-κB nuclear translocation, suggesting a dose-dependent effect. Regarding to the antioxidant action, through the Western blot analysis, we can see a significant increasing of INOS expression in a cell incubated with LPS stimulated medium compared to the control cell. And CBG at 2.5 micromolar slightly reduced INOS expression compared to the LPS group, but the pretreatment with the association of CBG 5 micromolar plus CBD 5 micromolar was able to counteract the INOS expression. Besides, CBD at 2.5 micromolar and 5 micromolar dose, both alone and in association with CBD, resulted in NRF2 nuclear translocation assisted by Western blot analysis. And CBG alone was able to activate the NRF2 nuclear translocation, and in combination therapy did not potentiate the antioxidant effect of CBD. The modulation of apoptosis, we can see that LPS stimulated medium induced neuroinflammation characterized by a loss of viability on differentiated motor neurons with apoptosis induction. Western blot showed a significant increase in BAX expression in the LPS group compared to the control group. And the pretreatment with all doses of CBG alone and in association with CBD at 2.5 micromolar dose reduced by BAX expression levels. And in addition, immunohistochemistry showed negative staining for BCL2 in the LPS group in figure B, compared to the control group figure A. The pretreatment with all doses of CBG induced the expression of BCL2, figure C and D. Instead, CBD given alone showed negative staining for BCL2 at 2.5 micromolar dose in figure A, being effective only at the dose of 5 micromolar in figure F. Both CBD and CBD combination induced the expression of the BCL2 factors, figure G and H, in a dose-dependent manner. We also investigate the expression of PPAR gamma assisted by immunohistochemistry. The pretreatment with CBG, both alone and in combination with CBD at all doses tested, induced the PPAR gamma expression in motor neuron exposed to the LPS stimulated medium. Only the activity of CBD in dose dependent when administered alone. In conclusion, in the present study, we confirmed the anti-inflammatory, antioxidant, and anti-apoptotic effect of CBG and CBD previously described. In particular, pretreatment with CBG at 2.5 and 5 micromolar doses alone and in combination with CBD at 2.5 and 5 micromolar doses was able to reduce neuroinflammation induced by a culture medium of LPS stimulated macrophage. In particular, the pretreatment with CBD at 5 micromolar dose decreased TNF alpha levels and increased the anti-inflammatory cytokine IL-10 and IL-37. CBD association at 5 micromolar dose also reduced NF-kappa-B nuclear factor activation with low degradation of the inhibitor of kappa-B alpha. CBD and CBD co-administered at 5 micromolar dose decreased INOS expression and increased NRF2 levels. Furthermore, the pretreatment with the association of two non-psychoactive cannabinoids downregulate BAX protein expression and upregulate BCL2 expression. Our data show also the anti-inflammatory and antioxidant and anti-apoptotic effect PPAR gamma mediated. Further evaluation of the effect of CBG and CBD combination on in vivo preclinical model of amyotrophic lateral sclerosis is therefore warranted. Our results provide preliminary support for the potential therapeutic application of CBG and CBD in motor neuron degenerative disease. Thank you for your attention.
Thank you, Dr. Paul Fagon, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presence and your presentation.
Thank you.
Okay, so moving on to our next presentation, it is from Dr. Natalia Meling from National Bogomolets Medical University, Ukraine. Hello, Dr. Natalia.
Hello.
Yeah,
Hello.
are you ready with your presentation?
Yes. Yes, of course. Just
Okay.
moment. Just moment. I include.
You are the new presenter now. You can share your screen with us for your presentation. Yes, it's visible. Yes.
Oh, visible. Thank you. Good. Nice. My presentation include information about investigation of nervous fibers in central nerve system after initiation of experimental allergic encephalomyelitis in rats and process of remyelinization study, which include influence of recombinant beta interferon. Our work was provided in Department of Histology and Embryology, National Bogomolets Medical University in Kiev. Objectives of the study. We observed differences between reactive changes of neurons in central nerve system in different parts of central nerve system, which include cerebrum, cerebellum, and spinal cord, lumbar part. And main basis of experimental work is investigation of changes of neurons and investigation of nerve fibers, process of demyelination and process of remyelination. Some words about multiple sclerosis. I hope all you know about main destruction in myelin sheaths, and which include process of destruction in proteins and active immune response and immune answer to proteins of myelin sheaths, and very important in its stage process of destruction oligodendrocytes. In our investigation, we observed the changes of neurons, because always more scientific work studied in more neuroglial cells, and very important to investigate neurons in different stages and different maybe destructions in its cells. Here on its slide information about risk factors, and which include age, family history, and race, climate, smoking, and autoimmune diseases, and influence of inflammation in general, viruses, bacteria, and next. Here are present information about scheme, what's happened in period of experimental autoimmune encephalomyelitis, which include influence of proteins, myelin sheaths, and adjuvant framed. It's a classical model of demyelination, and similarly to multiple sclerosis in human, include production of antibodies to myelin proteins, and in result, process of demyelination to start in animal experimental rats. And in general, we observe two periods of groups. In general, experimental animal groups include two periods: early stage and more late stage of demyelination. Here you see 34 animals, which include in investigation in more early period, 21 day, and in more late period after 39 days. And in its group include injections of recombinant beta interferon. It helps to provide process of remyelination and use in study of neurons and myelin sheaths in nerve fibers. In general, neurons was investigated by morphological methods. It's staining of crescent violet and toluidine blue by Nissl, and we observe three parts of central nerve system. I told cortex of cerebellum, and spinal cord. And why use crescent violet? Crescent violet very good determine changes of nerve fibers in light microscopy. Also, we observe nerve fibers by use electron microscopy. In general, all neurons to divide on three main groups. After staining of toluidine blue, very nice visible changes of neurons, and all neurons to divide by changes on three groups: normal, without some changes; moderate changes, which include reactive and damage of nucleolus. Nucleolus maybe stay more large, more light staining, and size of cell body of neurons in more large and not visible with Nissl substance, because cytoplasm and maybe more active process of production of proteins and not light cytoplasm. Next type, it's severe changes of neurons and include destruction process of nucleus. Nucleus stay more dark and not round shape, maybe present some waves, and process of heterochromatization include. It's similar to apoptosis. And its changes of neurons was seen on electron microscopy too. Here it's red after initiation of experimental allergic encephalomyelitis, and all rats to divide by clinical symptoms. You see on three groups, 4 columns without symptoms, and next with not strong symptoms, and continue. And you see after initiation of experimental allergic encephalomyelitis, more animals on early period demonstrate clinical symptoms. It's photo from histological specimens after staining of toluidine blue and crescent violet. Changes of neurons, very nice visible, severe and moderate changes. In early period, severe changes more, and more late period present moderate. Very interesting situation with changes of neurons in cerebellum, because Purkinje cells in cerebellum demonstrate not one layer in normal. In normal, Purkinje cells provide and form one layer. But after initiation of experimental allergic encephalomyelitis, maybe change location of neurons and form some sublayers. Next, very nice visible on slide neurons for Purkinje cells with severe changes, and shape of cell body stay not oval, not and stay more positive, form some waves and star shape maybe. Here it's a photo of spinal cord section, histological section, lumbar part, and visible changes of neurons after initiation of experimental allergic encephalomyelitis and influence of rebif, beta interferon. Next, its slide show changes of nerve fibers, myelinated nerve fibers in cerebrum, and process of demyelination form special picture which demonstrate destruction between lamels and decreased size of axial axon or dendrite, and its axon or dendrite stay not oval and change shape too. But after influence of rebif in the period of remyelination, the process of remyelination visible more good after beta interferon. Very interesting situation, I told, in cerebellum, a process of destruction Purkinje fibers in cortex of cerebellum maybe joining with a process destruction of myelin sheaths in part or in early period after initiation of encephalomyelitis, and demonstrate electron microscopy more severe destruction of myelin sheaths of nerve fibers. Next, it's photos from section spinal cord, and process of demyelination maybe to start more early by 21 days in rats, because was visible more nerve fibers without myelin sheaths, positive in normal, and it's maybe joined with more severe destruction of myelin. Here it's a table which shows percents of neurons without changes, with moderate changes, and with severe changes in different parts of central nerve system and in different terms of investigation. And to conclusion its part, I will say you about main points. Moderate changes predominate in experimental allergic encephalomyelitis in central nerve system, moderate changes of neurons. Next, destruction of myelin nerve fibers in central nerve system provide and show disorganization of lamels, destroyed of axial part of fiber, its axon or dendrite, and include more severe destructions in cerebellum. And here on its slide, main sentence about influence of interferon beta, very interesting. It's treatment with interferon beta include maybe more would say include more good changes to neurons, and maybe save neurons from destructions in experimental allergic encephalomyelitis in rats. Next part of my presentation include information of thymus because in our investigation we used not just only central nervous system parts, include thymus in rats, and very interesting changes of thymus in early period of investigation after 21st days. Why interesting? Because in cortex of lobules of thymus present some areas, light areas, similarly to maybe light central in nodules in a lymph node or maybe in spleen. It's another, but very interesting, forms groups of light areas, maybe include lymphoblasts, and its process show more active immune answer in early period. In cortex present, its groups similarly to nodules, but in more late period, in nodules not present or maybe present very small size nodules. And to conclusion to its short part about thymus, in the early term on an investigation, increase always medulla and cortex. In cortex of lobule in thymus present some light groups of lymphoblasts, and in more increased amount of lymphoblasts and increased amount of lymphocytes in general in more late period. And interferon beta was activate process of differentiation of lymphocytes, and it's very nice visible in more late period. I want to show to you its present photo from my printing book, which was printed in Acta Scientific Neurology in its year, and present information about our investigation more deeper. Thank you to your attention. It's a photo from my.
Thank you, Dr. Natalia, for your
from
presentation.
my country, from my city. Thank you.
Thank you for your presentation. Is anyone having any questions? Okay, I think there are no questions. Thank you once again, Dr. Natalia, for your presentation and your presence in the webinar.
Thank you.
Okay, moving on to our next presentation. It is from Dr. Jessica Maiulo from University Magna Grecia, Italy. Hello, Dr. Jessica. Are you ready with your presentation?
Just a moment.
Yeah, you are the new presenter now. You can share your screen with us and start your presentation. Yes, it's visible to all of us.
Really?
Yes, yes.
Just a moment. Okay. Good afternoon, everyone. First of all, let me introduce myself. My name is Jessica Maiuolo, and I'm a researcher in University Magna Grecia of Catanzaro, Italy. I would like to thank the organizers of this meeting for giving the opportunity to present my scientific work. Today, I'm going to talk about the role of ferrutinin on LPS-induced damage on oligodendrocytes and neurons. In last years, the scientific interest in plant derivatives and natural compounds has increased exponentially thanks to their innumerable beneficial properties in several body districts and against acute and chronic diseases. Terpenic compounds can be extracted from a wide range of plants, and their basic alchemical structure consists in a number of repeated isoprene units. Terpenic compounds can be divided in monoterpenes, sesquiterpenes, diterpenes, and others, but today I want to talk about sesquiterpenes. These compounds are very important because they have several properties, including antioxidant, anti-inflammatory, anti-cancer, anti-diabetic, among others. In addition, sesquiterpenes have a dose-dependent effect. In fact, low concentration of this compound tend to be protective, while higher concentration are toxic. And this occurs because sesquiterpenes modulate the permeability to the biological membranes to the cationic species. Among the richest plants in sesquiterpenes, the genus Ferula L is one of the most representative. Ferula L consists of 170 species that grown in Mediterranean areas, Northern Africa, and Central Asia. In Italy, we have 3 species of this plant, and they are Ferula communis L, Ferula glauca L, and Ferula arrigoni bocchieri L. The main sesquiterpene present in Ferula communis L is ferrutinin. This compound is very important because it has an interesting estrogenic-like property, and this occurs because a correct distance between oxygen of the hydroxyl group and the methyl group of the benzenic ring exists. In addition, we can say that ferrutinin has a chemical structure similar to 17-beta-estradiol 1. In this study, we evaluated the effect of ferrutinin on in vitro model of cultures of human oligodendrocytes and neurons exposed to lipopolysaccharides, LPS, a well-known component of gram-negative bacteria. Since oligodendrocytes MO3.13 are hybrid undifferentiated cells, and we had the need to work with mature oligodendrocytes, we differentiated them by treatment with PMA at a concentration of 100 nanomolar for 5 days. The same can be said about neurons, SH, SY, 5Y, and we differentiated them by the treatment with all trans-retinoic acid for 5 days at the concentration of 10 micromolar. After differentiation, both cell lines were placed in a structural insert place, and in particular, neurons and oligodendrocytes were placed at the bottom of the plate of the insert, respectively. The cellular migration was avoided thanks to the presence of a polyester membrane of 1 micrometer polis. When cells reached a confluence of 50%, they were treated with LPS 1 microgram per ml for 24 hours, or pre-treated with ferrutinin 33 nanomolar for 24 hours, and then exposed to LPS 1 microgram per ml for 24 hours. LPS, as already said, is a component of gram-negative bacteria. And because of its high resistance to degradation, it remains for a long time in the organism, providing a persistent inflammatory stimulus and producing several inflammatory cytokines, including interleukin-1 beta, interleukin-6, tumor necrosis factor, interferon gamma, and reactive C protein. In addition, LPS determined a dysfunction in several biomolecules, including lipids, DNA, RNA, and proteins, but also an increased inflammation, an apoptotic death, and expression of protein regulatory genes. In nervous system, LPS determined an increase in inflammation, increased inflammation, and accumulation of ROS. And these two effects can be considered a common denominator of several neurodegenerative diseases, including Alzheimer's disease, Parkinson's disease, amyotrophic lateral sclerosis, multiple sclerosis, Huntington's disease, and frontotemporal dementia. For this reason, it is important to reduce or eliminate inflammatory response, and the use of natural compounds with anti-inflammatory properties have been evaluated in several animal models of neurodegeneration and neuroinflammation. Since ferrutinin, as already said, has an interesting estrogenic-like property, preliminary experiments were carried out in order to evaluate if neurons and oligodendrocytes express the estrogenic receptor beta. As you can see in this slide, in panel A, it is shown the genetic information of this receptor. In panel B is shown the expression, the level expression of this protein normalized by the housekeeping protein actin, and in panel C is shown the expression of this receptor obtained by cytoperimetric analysis. On the right of the slide, relative quantification are shown, and it is important to emphasize that both cell lines express the same level of this receptor. Subsequently, we evaluated the effect of LPS on our experimental model. In particular, neurons and oligodendrocytes were treated with LPS, and as you can see in panel A, we have a statistically significant reduction in cellular viability, but oligodendrocytes were more vulnerable than neurons. After we tested also the effect of 17-beta-estradiol. As you can see in panel B, untreated cells and the cell treated with 17-beta-estradiol alone didn't show any variation in cellular viability, but when we treated both cell lines with LPS together, in addition with the 17-beta-estradiol, we appreciate an increase in cellular viability compared to the damage induced by treatment with LPS alone. In order to evaluate the effect of ferrutinin in our experimental model, we built a dose-response curve, and oligodendrocytes and the neurons were treated with the increasing concentration of ferrutinin. As you can see in panel A, low concentration from 1 nanomolar to 33 nanomolar didn't show any variation in cellular viability, while higher concentration from 66 to 500 nanomolar were toxic. In order to choose a unique concentration and to continue our experiments, we choose the higher non-toxic dose and 33 nanomolar. Next, we tested the effect also of ferritinine, and in particular, when we treated both cell lines chronic culture with ferritinine together with LPS, we have an increase compared to damage induced by treatment with LPS alone. In order to understand if cell death observed with treatment with LPS was apoptotic or necrotic, we stained the cells with annexin fit and PI. And as you can see in panel A, untreated cells and cells treated with ferritinine alone appeared annexin negative and PI negative, and this situation was compatible with viable cells. When we treated both cell lines with LPS, we had annexin positive and PI negative cells, and this is justified by the apoptotic death. But when we treated our cells with LPS together with ferritinine, we appreciate a reduction, significantly reduction in cellular in apoptotic death. And once again, oligodendrocytes were more vulnerable than neurons. Since it is known that LPS determined increasing amount of loss, we measured these molecules, and in particular, when neurons and oligodendrocytes chronic culture were treated with ferritinine alone, we didn't show any variation and any accumulation of loss amounts. When we treated cells with LPS, we have an increase in loss, but the treatment with ferritinine together with LPS determined a decrease, a statistically significant decrease in loss accumulation. In this experiment, hydrogen peroxide was used as a positive control. The same can be said about the biological biomarker MDA, whose production occurs when we have lipid peroxidation reactions. And once again, neurons treated with LPS evidenced an increase in MDA amount, and this increase was reduced by treatment with ferritinine, and when oligodendrocytes were treated with LPS, we had a higher increase in MDA compared to neurons. And lastly, we have measured the activity of three antioxidant enzymes present in mammalian cells: catalase, superoxide dismutase, and glutathione peroxidase. As you can see in panel C and D, the treatment with LPS determined a decrease in activity of catalase. In particular, we measured the activity of this enzyme at several times: 1 hour, 1, 6, 9, 18, 24 hours after treatment with LPS. And as you can see in panel C, the treatment with LPS determined in neurons a decrease already 9 hours after treatment, 9 hours forward. The treatment with the ferritinine was able to reduce these effects. In oligonucleotides, we have that this effect was higher than neurons. The behavior of the superoxide dismutase and glutathione peroxidase was similar to the enzyme catalase. So, with this obtained data, we can conclude that, first of all, the co-cultured oligonucleotides and neurons were a good experimental model to investigate because of the crosstalk that physiologically exists between these cell lines. In particular, oligonucleotides were found to be more vulnerable than neurons. Second of all, pretreatment with the protein has highly protected against the damage caused by LPS in both cell lines. And third of all, under inflammatory conditions, the antioxidative profile of oligonucleotides is greatly compromised, so this information could be important in the treatment of the demyelinating disease. In just one moment. I can. Okay. In this scenario, we can say for the first time that ferritin was able to protect the damage caused by treatment with LPS, and ferritin may be used as a support strategy in neurodegenerative and demyelinating diseases. That's all, and I thank you for your attention.
Thank you, Dr. Jessica, for your presentation. Is anyone having any questions? Yes, sir, there are no questions. Thank you once again, Dr. Jessica, for your presence and your presentation.
Thank you. Thank you so much.
Okay, so our next presentation is from Dr. Maria Helena from University of Sao Paulo, Brazil. Hello, Dr. Maria. Are you ready with your presentation? Hello, Dr. Maria. Are you with us? Okay, I think she is not active now. So we will move towards the next poster presentations. I would request Dr. Iliana Ramazzina from University of Parma, Italy, to present her poster with us now. Yeah, hello, Dr. Iliana. Are you ready with your presentation?
Yes, I'm ready.
Okay. So, yes, you are the presenter now. You can share your screen with us and start your presentation.
Okay. Can you see? Okay.
Yes, we can able to see your presentation.
Thank you. First of all, I would like to thank the organizer of the Congress for this opportunity. The main focus of my research is to shed light on the role exerted by the protein chaperone in the counteracting the abnormal aggregation protein that is a specific event in neurodegenerative disease. The impact, just a moment. Okay. The integrity of proteostasis network is essential to assure cell viability, as its failure can lead to the abnormal protein aggregation that is closely related to human neurodegenerative disease. In particular, the aberrant alpha-synuclein aggregation process is associated with the onset of Parkinson's disease. Key effectors of proteostasis network are chaperone. They are proteins that ensure proper protein folding and cooperate with the cell degradative system. Targeting chaperone to reduce the burden of alpha-synuclein aggregate toxicity is an ongoing research challenge with the aim to slow down or, if possible, to stop the development of the neurodegenerative disease. With particular regard to Parkinson's disease, it has been shown that its shock protein 70, 19, and small its shock protein like shock protein 27 or alpha-beta crystalline are able to protect cell against alpha-synuclein aggregate toxicity. Clustering is a glycoprotein that exhibits chaperone activity. CLU bind unfolded protein and is able to maintain them in a soluble state. CLU can also favor protein degradation, targeting unfolded proteins to lysosome. CLU also can act as a signaling molecule interfering with an 8Kb pathway. Collectively, this many functions of clustering highlight its pivotal role under proteostatic cell stress condition. At present, the role of clustering has been more extensively investigated with regard to Alzheimer's disease, where its significant impact on the formation, clearance, and cytotoxicity of amyloid beta peptide. The role exerted by clustering in the Parkinson's disease has not been extensively elucidated yet. The first study that reported a link between clustering and alpha-synuclein showed that clustering colocalized with alpha-synuclein positive aggregates in biopsy sample of patients affected by alpha-synucleinopathies. Moreover, clustering has been identified as a protein associated to alpha-synuclein positive aggregate in cells exposed to rotenone. Independent study found that clustering expression is upregulated in plasma and in cerebrospinal fluid of PD patient. And recently, a study reported that clustering has been detected in serum-derived exosome of patients affected by Parkinson's disease. And of particularly interesting, the content of clustering increased from mild to severe disease. So the focus of our study was to shed light on the role exerted by clustering in the cellular response caused by both alpha-synuclein upregulation and aggregation process. We use SHSY5 neuron-like cells to obtain a stable cell line overexpressing alpha-synuclein that we name SH-SYN, and we obtain also the control cell SH-MOC. In this experimental setting, we study the role exerted by clustering both in condition of mild and strong proteostasis impairment. The mild condition has been obtained by synuclein overexpression. Instead, the strong impairment condition was obtained thanks to alpha-synuclein overexpression and proteasome inhibitor MG132 treatment. In this setting, we perform loss of function experiment by using clustering siRNA specific sequences. First of all, we characterized our experimental model, and to this aim, we studied the effect of alpha-synuclein overexpression in terms of cell viability, caspase 3-7 activity, and unfolded protein response. We demonstrated that the alpha-synuclein overexpression was correlated to a statistical reduction of cell viability and with an increase of caspase 3-7 activity. To evaluate if alpha-synuclein overexpression was a stimulus sufficient to induce endoplasmic reticulum stress, we check for the expression of UPR markers by qPCR analysis. We found that the expression of BIP or GRP78, an early sensor of unfolded protein response, was significantly increased in SH-SYN compared to SH-MOC, while the other markers checked were not significantly increased. Then we evaluate the expression of clustering in response to alpha-synuclein overexpression, and we also evaluate the expression of other well-characterized chaperone that were extensively studied with regard to neurodegenerative disease. Specifically, we studied ixoprotein 27, ixoprotein 70, and 19. Our result clearly demonstrated that clustering mRNA level was upregulated in SH-SYN compared to SH-MOC, and interestingly, the other mRNA expression did not change. Then we evaluated the expression profile at protein level and by Western blot. And for this aim, we evaluated the presence of the protein in a different buffer fraction, extracting subsequently, and each of these buffer was characterized by an increase in detergent strength. So we analyzed the presence of the protein in 1% Triton X100, in 2% SDS fraction, and in the pellet fraction. As expected, when the membrane was immunoblotted with anti-clustering antibody, we detected in all the fraction two immunoreactive band. The band corresponded to precursor protein form of about 64 kilodalton and the clustering intracellular mature form of about 40 kilodalton. In agreement with our PCR result, clustering protein was either in SH-SYN compared to control cells. Then we performed the same analysis, but in a condition of strong proteostasis impairment. And we found a significant increase in both mRNA clustering mRNA expression and at protein level. In particular, we are able to demonstrate an increase of clustering presence in 2% SDS fraction and in the pellet fraction, the same fraction in which we are able to detect alpha-synuclein oligomeric and high molecular weight forms, as you can see in the low part of the slide when the membrane is blotted with alpha-synuclein antibody. On the basis of these results, we decided to investigate the presence of a specific relation between clustering and alpha-synuclein. So we performed confocal microscopy analysis to verify whether these two proteins colocalized inside the cells. In SH-SYN, the acquired image revealed a weak green fluorescence signal with a cytoplasmatic puntate pattern for clustering, and revealed a signal more marked and diffuse in red for the alpha-synuclein protein. Following MG132 treatment, as you can see from this representative picture, the merge signal indicates a partial colocalization of these two proteins. On the basis of this result, we decided to investigate the possible physical interaction between these two proteins. So we perform a co-immunoprecipitation assay. We efficiently immunoprecipitated clustering from SH-SYN lysate, as you can see in the lane of immunoprecipitated reaction when the membrane was probed with anti-clustering antibody. When the membrane, an immunoreactive band corresponding to alpha-synuclein was detected in the immunoprecipitated lane when the membrane was probed with anti-synuclein antibody, demonstrating that synuclein is a clustering client protein. Finally, to test the hypothesis that clustering may interfere with the synuclein aggregation process, we set up loss of function study using clustering siRNA specific sequences, both in mild and strong proteostasis impairment condition. As you can see from this picture, an effective and specific reduction of clustering at both mRNA and protein level was achieved in transfected cell compared to negative control. In mild proteostasis impairment condition, we found a slight increase in synuclein high molecular weight forms in the pellet fraction, comparing transfected cell with negative control. When clustering down regulation was combined with the MG132 treatment, synuclein high molecular weight form level were markedly increased in the cell pellet, comparing again cells, transfected cell with negative control. Overall, we demonstrated for the first time that clustering is part of the biochemical responses triggered by the cell to manage with alpha-synuclein aggregation process. And moreover, we demonstrated that clustering down regulation favor or exacerbate our alpha-synuclein aggregation process, suggesting that the chaperone involved in the dynamic process leading to onset of synucleinopathy or Parkinson's disease, which are our next plan. First of all, would like to confirm the ability of intracellular clustering to counteract the aggregation alpha-synuclein and its detrimental effect. And we would like to change our experimental model and using the next time clustering wild type and clustering knockout mice primary hippocampal neurons. Moreover, we would like to evaluate whether clustering modulate the extracellular vesicle cargo, play a role in cell-to-cell spreading of alpha-synuclein aggregates, determining so a diffuse of the pathology. Thank you very much for your attention.
Thank you, Dr. Iliana, for your presentation. Is anyone having any questions? Okay, I think there are no questions. Thank you once again for your presence and your presentation.
Thank you.
Okay, so our next presenter will be Dr. Maria Helena from University of Sao Paulo, Brazil. Hello, Dr. Maria, are you ready with your presentation?
Hello, are you listening?
Yes, yes. Please share your screen with us. You are the presenter now. Yes, your screen is visible to us. Now you can start your presentation.
Okay. 1 minute, please. Okay. Good afternoon. First, I would like to thank these event's organizers for the great honor of standing before you to talk about the Zika virus and my work regarding the congenital Zika syndrome. In 2015, Brazil warned the world about an explosion of microcephaly cases in its territory, concomitant with numerous cases of Zika virus infection. Until then, congenital microcephaly was credited to genetic or environmental brain damage, resulting from neuronal hypoxia or infection diseases well known to us, such as rubella, cytomegalovirus, toxoplasmosis, to name but a few. Let us recall that the first cases of human Zika virus infection were reported in Africa in 1952, then in Asia in 1977, and by 2007, only 14 cases had been reported as Zika virus infection in humans. In 2007, the virus arrived in the Yap Island in Micronesia, and between October 2013 and April 2014, there was an outbreak in French Polynesia, where there are reports of symptomatic patients and neurological complications, such as Guillain-Barré. Officially, 32,000 inhabitants of the archipelago showed symptoms of the disease, but surveys carried out by local scientists indicate that the number of infected people was much higher. At the time, the outbreak was seen as mild dengue that indeed with no serious traces. However, when analyzing the data from a later period, the health authorities observed a higher occurrence of malformations in the central nervous system of fetuses and newborns. From one case, it increased to at least 70 cases per year after the Zika virus. And in 2015, the virus arrived in Brazil. The Zika virus is enveloped single-stranded, no-segmented RNA virus of the flavivirus family and the flavivirus genus. It was recovered and isolated in 1947 in the Zika forest in the Republic of Uganda, at first originating from the rhesus mantri. The primary means of the transmission of the Zika virus occurs through the bite of the mosquito Aedes aegypti, Zika virus being an arbovirus. It is so named because part of its replication cycle occurs in insects. There are more than 545 arbovirus species now, but about 150 of them cause disease in humans. The Aedes aegypti mosquito originates from Egypt and came to Brazil during slavery from ships that brought slaves from Africa, with their eggs attached to the outside of the vessels. This mosquito was scientifically described for the first time in 1762. The definitive name Aedes aegypti was established in 1818 after the description of the genus Aedes. It is an urban mosquito, extremely adaptable, and has a special appetite for human blood. So it has become an efficient vector for the transmission of various diseases such as yellow fever, dengue, chikungunya, and now Zika. The Zika virus's main symptoms are red itchy patches on the skin, fever, red eyes with no secretion, inflammation or pain in the joints, muscle pain, headache, and backache. Less frequently, there are also reports of swelling, sore throat, coughing, and vomiting. According to the literature, only 18% of people have clinical manifestation of the disease. Therefore, a large percentage of people may have the disease and not know it. Signs and symptoms usually last from 2 to 7 days, and treatment is only symptomatic. Occasionally, there are reports of simultaneous infections, something which happened in some regions of Brazil, where we had simultaneous cases of Zika and chikungunya in pregnant women. From 2015 to 2018, there were 239,742 cases of Zika virus infection reported in Brazil, and concomitantly, there was a sudden increase in cases of microcephaly, what suggests an association. The primary means of transmission of Zika, the primary means of Zika, wait a minute, please. In February and March 2016, in Pernambuco, Brazil, the Ageu Magalhães and Fiocruz Research Center confirmed 12 cases of microcephaly related to the Zika virus by detection the IgM antibody in the cerebral spinal fluid of infants. Another study detected the Zika virus genome and the anti-Zika virus IgM antibody in the amniotic fluid of pregnant women with microcephaly fetuses. Another study detected the Zika virus genome and Zika virus IgM antibody in the amniotic fluid in pregnant women with microcephaly fetuses. Soon afterward, some autopsy studies led to a complete recovery of the Zika virus genome from the brain of the fetus. Data from Brazilian surveys on the epidemic led the world to recognize the situation between Zika virus infection and microcephaly. Finally, in April 2016, the U.S. Center of Disease Control and Prevention concluded that there really was a causal relationship between prenatal Zika virus infection, microcephaly, and other serious malformation. Brain involved and the presence of microcephaly is the main feature of Zika congenital syndrome. Zika virus crossed the transplantation barrier, has strong tropism for neuroprogenitor cells, which are undergoing intense replication, leading to apoptosis and necrosis of neural cells, using all the fantastic neural apparatus from its own replication. Afterward, the neural cells activate the defense system, becoming paralyzed and no longer developing. After that, the cells die. As a result, the number of neurons is much smaller in the affected fetus, with neural death, which occurs in around 12 days. There is a sudden and brutal reduction in brain volume, which is why the cranial sutures are squashed, and there is permanence of the occipital bone and redundant scalp in the region. The scientists have found changes in 500 genes and proteins inside cells which survived the Zika virus attack, which led to brain malfunction. The most common found and recently reported changes in children reported with Zika congenital syndrome are, in addition to microcephaly, calcifications of the central nervous system, ventricular dilatation, hydrocephalus, hydroencephaly, development abnormalities with neuronal migration disorders, craniofacial disproportion, ocular and hearing changes, hyperexcitability, hyperirritability. Changes in muscle tone with intense spasticity and pyramidalism, pervasive development disorders, and epilepsy, joint deformities, and arthropodis. It should be noted that there are no reports in the literature about other congenital infection in humans associated with arthropodis. During the Zika virus epidemic in Brazil, from January 2015 to December 2018, there were 278,790 people infected, in approximately 22,000 were pregnant women. In our state, Mato Grosso do Sul, in the same period, 427 cases were confirmed, and 185 of these cases occurred in pregnant women. There were 16 cases of Zika congenital syndrome, and unfortunately, only 11 of these cases participate in current study. The study did not include those who did not meet the diagnostic criteria congenital malformation, even when the mother presented laboratory confirmation of Zika infection. The status of maternal infection was defined by serology, PCR performed at the Central Public Health Laboratory in the state of Mato Grosso do Sul. Obviously, those who presented congenital malformation caused by other infection agent or by chromosomal alteration did not participate in this study either. This study was approved by the Research Ethics Committee of the Federal University of Mato Grosso do Sul. The methodology consisted of observation clinical evaluation of 11 children with the Zika virus syndrome who underwent 2 clinical trials from October 2018 to February 2020. The following were evaluated: head circumference ground, neuropsychomotor development, presence or lack of spasticity, presence or absence of epilepsy, and its pharmacological treatment. Regarding the results, 7 of 11 children in the represented study already had intrauterine microcephaly. Another 3 children had deceleration of cephalic perimeter after birth, which evolved to microcephaly, and only 1 child did not develop microcephaly, but presents congenital intracranial calcification. Craniofacial disproportion, craniofacial disproportion redundant scalp skin were found in 80 children. Hydrocephalus was present in 5 cases. Cerebral palsy was identified in 9 children with intensive spasticity, fibrotendinous retraction, pseudobulbar syndrome, and global delay. At the first clinical evaluation, 4 children had no history of seizures, remaining so. The other 7 children were diagnosed with epilepsy at the first assessment. 3 of those children with epilepsy spasm, EEG tracing with hypsarrhythmia, all compatible with West syndrome. Another 3 children had focal epilepsy, and there was 1 case of generalized epilepsy. In the second evaluation, we noticed that 2 of the children who previously had West syndrome maintained this condition, and the third evolved to focal epilepsy. Also, 1 previous case of focal epilepsy progressed to West syndrome. The epilepsy was refractory and managed by polytherapy, mainly with the association of levetiracetam and vigabatrin. Visual and ocular motricity changes were observed in 4 out of 11 cases. 3 of these cases had optic nerve atrophy and retinal microlesions with low vision, and 1 case had glaucoma and strabismus. Auditory impairment was diagnosed in only 1 child, but with bilateral hearing loss. Malnutrition due to the association of muscle hypertonia and pseudobulbar syndrome found in 7 children. There was 1 case of child obesity diagnosed. Arthrogryposis was not identified in the children in this study. The deceleration of the ground of the cephalic perimeter after birth evolved to microcephaly, suggesting the possibility of continuation of the viral replication of the Zika virus in the brain of children infected in the uterus, even after birth. It has been emphasized the importance and the need of studies which assess these children throughout their lives, and whereas studies with access children exposed to Zika virus during pregnancy, but who did not develop congenital changes related to the Zika virus at birth. Once again, I would like to thank you for the opportunity to put this work forward and say that I'm currently following the neuropsychomotor development of children whose mother had positive serology for Zika virus during pregnancy, but who themselves have kept their serology negative after birth. My goal is to bring that date for the next Congress. Thank you. And any question, please send it my email.
Thank you, Dr. Maria, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presentation and your presence.
Thank you very much. Bye.
Okay, bye-bye. Moving on to our next presentation, it is from Dr. Manuela Siccheri from American University of Integrative Sciences School of Medicine, Barbados. Hello, Dr. Manuela.
Good afternoon.
Yeah, good afternoon. Are you ready with your presentation?
Yes, I am.
Okay, I'm going to make you the presenter now. Yeah, it's done. Now you can share your screen with us and start your presentation.
Okay.
Yes, it's perfect, visible.
Perfect. So greetings, everyone. My name is Manuela Kechadi, and I'm a medical student from American University of Integrative Sciences, or AUIS for short, of Barbados. Today, I would like to present a preliminary result of our bigger research project, which was focused on assessing sleep quality, depression, stress and anxiety in medical students during online learning and COVID-19 pandemic. So today, I will present results related to the sleep quality in medical students during online learning and the pandemic. As we all know, at the start of the pandemic, the switch to online classes posed challenges for students, and this significantly affected the physical and mental health of many medical students. Sleep quality is a crucial component of mental health and well-being, and based on recent published data, lack of sleep shows a strong correlation with poor academic performance and increase in stress, anxiety, and depression levels in medical students. During the first phase of our research, we decided to evaluate sleep quality in our medical students in relation to their online learning during the pandemic. We conducted a cross-sectional study where the main dependent was sleep quality, and we used the Pittsburgh Sleep Quality Index program, or PSQI. We analyzed 7 components, namely sleep duration, disturbance, latency, efficiency, quality, medication used for sleep, and daytime dysfunction caused by lack of adequate sleep. The PSQI's socio-demographic questionnaire were released to students by using an online form with one cutoff point, which was in May 2021. This research project was conducted as an in-school study. The analysis of the socio-demographic questionnaire shows that the majority of our respondents, or about 45%, were from the USA, about 30% from Canada, and the rest of the participants were from India, Barbados, and Nigeria. 60% of the respondents were female. And in terms of diet and nutrition, 75% declared healthy nutritional intake. And while assessing screen time, the majority, or 55% of the respondents, stated that they spent 10 or more hours on screen. This correlated with a p-value of 0.019. As you can see, out of the 7 components that we analyzed, sleep latency, duration, efficiency, and daytime dysfunction were the most affected. When assessing component 2, or sleep latency, our research showed that approximately 40% of the respondents indicated that it takes approximately 15 minutes for them to fall asleep, and those that reported that it takes longer than 30 minutes to fall asleep happened once or twice a week, as you can see in this graph. And this correlated for the majority, or 35% of the respondents. When we looked at component 1, or sleep quality, students reported sleeping quality from very bad to very good, and the data showed no significant differences with a p-value of 0.49. About 50% of the students reported sleeping less than 5 hours per night, and our p-value for this was actually 0.012, and the majority of our students reported going to bed around midnight, as you can see in this graph, and waking up between 6 and 10 a.m. We hypothesized that the variances in wake-up time might be due to students being in different time zones, as well as it might be correlating with the time of the start of the online classes. This result is significantly different in comparison to the expected values, since the average sleep time should be about 7 hours. On this chart, you can also clearly identify the two red peaks representing the wake-up time for students. What is interesting is that all students came to bed approximately at the same time, which was around midnight. In terms of sleep disturbance, 20% of the respondents reported waking up to use the bathroom in the middle of the night or early in the morning, and using the bathroom was the most common reason for the sleep disturbance. We speculated that sleep interruption for bathroom use might be attributed to increased use of coffee or other caffeinated beverages that affect sleep cycle and can increase awakening of students. Components 6 and 7, not shown in any of these graphs, which assessed use of medication for sleep and daytime dysfunction due to sleepiness. Of the respondents, 95% stated that there are no concerns in engaging in activities or other daytime dysfunction. The prevalence of sleep disturbance was 75%, while 35% of the students reported mild to severe sleep problems. Also, it is notable that the mean time spent in bed was approximately 6.5 hours, with a standard deviation of 2 hours. In conclusion, our research revealed that although students reported low sleep duration, there was a high sleep efficacy. Also, sleep quality of medical students was negatively affected by the COVID-19 pandemic. For the future, we call for further research to help develop strategies that support students' mental, physical, professional, and educational well-being. Thank you.
Yeah, thank you, Dr. Manuela, for your presentation. Is anyone having any questions? Okay, I think there are no questions. Thank you once again for your presence and your presentation.
Thank you for this opportunity.
Yes, thank you. So our next presenter will be Dr. Ismat Babikar from University of Medical Science and Technology, Sudan. Hello, Dr. Ismat. Are you connected with us? I think he is not connected with us. And so we have a video presentation from Georgia Nectaria Porphyri from Aristotle University, Greece. So I will be playing the video presentation of her as she is unable to present at our webinar. Yes, I'm going to share my screen with all of you. And please let us know, is it audible and visible to all of you? Is it visible to all of you, my screen?
Yes, it is. Yes, thank you.
Yes, okay, I'm going to play the presentation. According to the World Health Organization, mental health is defined as a state of well-being in which the individual realizes his abilities, is able to cope with any adversities of life, and can work productively as well as contribute to his community. According to the American Psychiatric Association, mental illness is defined as health disorders that involve changes in emotion, thought, or behavior, or a combination of these. The social stigma that accompanies mental illness has a long tradition and has been recognized as a major barrier to seeking help from mental health professionals. The word stigma comes from the Greek verb stigma, which means a great remark on the surface and has almost endlessly and universally negative meaning. In ancient Greece, masks were placed on slaves to identify their position in the social structure and indicate that they were of lesser value. In the past, in Greece, neurology and psychiatry was a single specialty. The separation of the two disciplines was realized in the year of 1981. Of all the medical specialties, neurology is the one that is closest to psychiatry. Psychiatry and neurology have a common root and both share a common basis in neuroscience. There is much more that unites neurology and psychiatry than divides. In modern Greece, despite the psychiatric reforms, stigmatization phenomena are still observed. A survey conducted in the Provincial Hospital Greece showed that health professionals, despite being more optimistic about the abilities of the mentally ill, seem to be prejudiced, proving that the stigma of the mentally ill still persists. From additional research conducted in psychiatric structures in various locations in Greece, as Thessaloniki serves Larissa, additional concerns arose. According to the results of the research, health professionals appear less and less willing to have a positive attitude towards the treatment of mental illness, to suggest improving the quality of care provided, and to encourage the mentally ill to equal participation and integration in the community. Health personnel should combat the psychiatric stigma, be aware of the mental illness's nature, as well as the rights and peculiarities of the mentally ill, contributing to the effective reduction of any discrimination. Our objective was the collection and processing of data that will lead to conclusions which will contribute to the equal treatment of pathological as well as mental illness. The sample of the research was up to 100 employees of the General Hospital Papageliou Thessaloniki, regardless of rank, specialty, or position. The approach of each participant was realized by the management of each respective service. The personnel of the psychiatric clinic of the hospital was excluded from the research. After being informed about the research and after giving consent to participate, the participants were asked to complete various questionnaires concerning demographic data, opinion about mental illness, social distance from psychiatric patients, and the degree of familiarity with mental illness. One of the main causes of mental illness is the lack of self-discipline and willpower. 10% strongly agree, 18% agree, 23% somewhat agree, 20% somewhat disagree, 16% disagree, and 13% strongly disagree. The law should allow Robina to divorce her husband as soon as he has been admitted in a psychiatric hospital. 1% strongly agreed, 6% agreed, 22% somewhat agreed, 29% somewhat disagreed, 29% disagreed, 13% strongly disagreed. Patients in psychiatric hospitals are in many ways like children. 4% strongly agreed, 26% agreed, 34% somewhat agreed, 60% somewhat disagreed, 50% disagreed, 6% strongly disagreed.
People who are mentally ill let their emotions control them, while normal people think things out. 3% strongly agree, 20% agree, 20% somewhat agree, 22% somewhat disagree, 28% disagree, 8% strongly disagree. Although they usually are not aware of it, many people become mentally ill about the difficulties of everyday life. 2% strongly agree, 9% agree, 28% somewhat agree, 18% somewhat disagree, 27% disagree, 8% strongly disagree. Most women who were once patients in a psychiatric hospital could be trusted as babysitters. 3% strongly agree, 4% agree, 33% somewhat agrees, 36% somewhat disagree, 23% disagree, 7% strongly disagree. Would you be willing to trust someone with mental illness to take care of and treat it? 52% definitely unwilling, 42% unwilling, 4% willing, 2% definitely willing. Would you like your child to marry mentally? 39% definitely unwilling, 47% unwilling, 12% willing, 3% definitely willing. I have worked with a person who had a mental illness and no place of employment. 64% agree, 36% disagree. A family friend has mental illness, 38% agree, 62% disagree. In order to demolish the walls of prejudice and ignorance and in order to advance the process of stigmatization, health professionals must know the nature and the treatment of the mental disease as well as the rights of the mentally ill. Priority should be given to combating attitudes and beliefs that reproduce discrimination and stigma in order to establish a more positive attitude towards the potential of the mentally ill as well as his social acceptance and participation. The training and education of health professionals regarding mental disease through various programs, seminars and workshops will contribute to the better understanding of the mental ill since ignorance seems to be the main cause of expression of stigmatizing behaviors. The emergence of positive examples from people suffering from mental disorder and at the same time living a normal life in order to eliminate the wrong perception of helplessness and dangerousness of the mentally ill would be quite useful. Thank you very much for your attention.
Thank you all of you for listening to the presentation of Dr. Georgia. Now with us, Dr. Ismat has joined with us. So next presentation is from Dr. Ismat Babika from University of Medical Sciences and Technology, Sudan.
Hello, everybody.
Yeah, I'm going to make the presenter. Yes, it's done. Please share your screen with us and start your presentation.
Okay. Should I open the PowerPoint or the PDF file for the poster?
Sorry, Dr. Ismat, is there any problem?
Should I open the PowerPoint or the PDF file?
You need to open the PowerPoint.
Okay. Okay. I'm opening the PowerPoint.
Yeah, please share your screen with us. It's not visible to us.
I'm having some difficulty. The
Is it
share
asking
option
for?
is not available.
No, it's the third button. In the bottom of your screen, you will have 4 buttons, right? My camera screen. Please click on the screen
Okay.
button.
Okay. I clicked on share.
Yeah. Is it asking for any permissions on your system?
Not currently. I clicked on the share option, but
Okay.
okay.
Yes, now it's visible to us.
Okay. Uh, is it visible right now?
Yes, yes.
Can I start?
Yes, you can start with your presentation.
First of all, I'm very sorry for the delay. My name is Dr. Asma Babikir. I'm a medical officer from Sudan. Today, I'm going to be talking about research article in epilepsy. The research article title is Community Awareness of Which Seizure Types Should Present to Healthcare Provider, a Potential Risk Factor of Epilepsy Treatment Gap. Well, when we break down the title, what we were trying to do is we were trying to study the knowledge of the Sudanese community of the different seizure descriptions. Which seizure description should present to doctors? This is a potential risk factor of epilepsy treatment gap. So first of all, me and my colleagues have no conflict of interest to disclose. Well, let's start by defining epilepsy treatment gap. Epilepsy treatment gap is the proportion of people with epilepsy who are either not receiving anti-epileptic drugs or who are not being treated efficiently. So epilepsy treatment gap is any risk factor of epilepsy treatment gap fall under one of two categories. The first is the participant deficits in healthcare seeking behavior. So the participants with epilepsy are not coming to doctors. And the second part is the participant, and the second part is the participant are not complying with the treatment. So what we were trying to do in this study, we were trying to investigate two potential risk factors leading to healthcare seeking behavior deficits. These are whether our participants in Sudan were aware that doctors are the primary healthcare providers for people with epilepsy or not. And the second question that we were trying to answer is whether the participants were aware of the different seizure descriptions and what seizure description they think should present to doctor. So moving on, our study were conducted only in the highly educated community in Sudan. Our hypothesis was that the educated community in Sudan lacks the awareness of the different seizure presentation and only consider epilepsy the generalized tonic-clonic seizure. When we conducted this study, we conducted the study in the highly educated community because there is a literature supporting that people with lower educational level are less aware of epilepsy at all. So we were trying to study the research article only in the educated community in Sudan. In this study, when we say the highly educated community, we are referring to people with university degree education or higher education. So the objective, as mentioned, we were trying to assess whether the participants were aware of which seizure description should present to the doctor. In methods, our study design, this article was a cross-sectional descriptive study that was conducted using Google Form. It's an internet-based survey that was conducted between January and April 2018. As you all know that Google Forms is an online tool that is used to collect data from participants and upload this data to a spreadsheet, which will later be used for data analysis. The information will automatically be connected to the spreadsheet. In Google Form, we included a consent form from our participants, and we did not collect any personal identifying information or email addresses from our participants. This method was used to increase the sample size. Our targeted population was Sudanese population who reside in Sudan with university degree or higher education. We excluded participants who are less than 18 years of age. Now moving on to the variables of the questionnaire. Our questionnaire consisted of age of participants, gender of participants, and a question assessing whether the participants were aware that doctors are the primary care providers. The question states that which do you believe that doctors are the primary care providers for people with epilepsy? It's a yes or no question. Another item in our questionnaire is a statement evaluating the source of information of the participants regarding epilepsy. So participants could obtain their information regarding epilepsy either from a scientific source, i.e. people in the medical field or scientific book, or from non-scientific source like laymen in the community or social media. And the last item in the questionnaire was the question describing the description of generalized tonic-clonic seizures, focal seizures, absence seizures, and myoclonic seizures. And then we asked the participant which seizure description do you think should seek medical care. The results, 467 participants completed the questionnaire, of whom 60% were females. The mean age of our participants was 28 years, so the data was positively skewed. This to be expected because the people who are using social media are younger compared to the general Sudanese population. So this article may not be representative of the entire Sudanese population. 2/3 of participants obtained their information from non-scientific sources. 84% of participants were aware that doctors are the primary healthcare providers for people with epilepsy. Now moving on to the question dealing with which seizure description should present a doctor. As expected, 92% of participants were aware that people with description of generalized tonic-clonic seizure should seek health care, while only 2/3 of participants were aware that description of myoclonic seizure and focal seizures requires healthcare provider evaluation. This is in comparison to only 1/3 of participants were aware that people with symptomatology of absence seizure should present to doctor. In this table, in table one shows the demographic data of our participants.
Yeah, hello, Dr. Isma. Sorry for the interruption, but the slides
Hello.
are not moving forward.
Okay, why is that?
Yes, you need to play the slideshow.
Yes, I was doing the slideshow.
Okay.
How about now?
Yes, it's in the 15th slide.
Yes.
Yes. Okay, once you start the description, please change the slide so that the other speakers can see the information on your presentation.
What should I do? Is it visible a table right now?
Yeah, it is visible. It is the 15th slide is visible to us, but you need to change the slide once you go on to the for further presentation. You need to move on the slide.
Yes, when I'm not moving, that means I'm just telling information from my
Okay then.
So,
okay, please continue.
Okay. In this table, we are describing the demographic data of participants, and we mentioned that 60% of participants obtain their information from scientific sources, and 61% obtain from non-scientific sources. In this table, these are the main items, the two objectives that we want to describe. 83% of participants, as shown in the table, believe that doctors are the primary healthcare provider for people with epilepsy. And in the next part of the table, we are describing the which seizure description should present a doctor. As seen, generalized tonic-clonic seizure symptomatology is the highest, followed by focal seizure and myoclonic seizure, while only 1/3 of participants believe that people with absence seizure should seek medical care. Moving on, in this table, it's a chi-square description of percentages of people who think that epilepsy description should present to doctor. The only significant part of this table is that people with higher education, i.e. people who obtained education further higher than university degree, master's degree or something like that in our sample, achieved significant knowledge in myoclonic seizures. compared to people with only university education. The limitations of our study, first of all, because we conducted the study in social media groups, not using the email address of participants, we could not calculate the response rate. In order to do that, we should have used different survey methods like monkey survey and collect data from email addresses. But this is not feasible in Sudan, as most participants in Sudan are not using email, they're using Facebook and social media groups. Another limitation I would add here is that we included only the highly educated community in Sudan. I would believe that it would be better if we included people with lower education in order for comparison purposes. Finally, in the conclusion, this study demonstrated poor awareness about the necessity to present to healthcare provider when experiencing this symptomatology of focal seizures and absence seizure. As we hypothesized, people only relate epilepsy as a generalized tonic-clonic seizure. Only convulsive part where people lose consciousness. When they were asked a description of absence seizure, focal seizure, or myoclonic jerks, they usually don't recognize this as seizure or ask to present to healthcare provider. So we hypothesize that this lack of awareness may contribute to epilepsy treatment gap as mentioned, and we recommend further studies to examine this hypothesis. Thank you.
Thank you, Dr. Ismat, for your presentation. Is anyone having
Yeah,
any questions? Okay,
is
thank you
there
once
any
again
question?
for your presence. I think there are no questions from anyone.
Okay, you're welcome.
Okay, so as we are having one more presentation from Dr. Svetkova Maria, but she has not yet joined with us, we will wait for 5 more minutes. I will try to contact her. Yeah, hello, Dr. Svetkova. She has joined with us.
Yes, good afternoon.
Good afternoon. Are you ready with your presentation?
One moment.
Okay. I think Dr. Svetkova has left with us. We will wait for 5 more minutes. I think she is having some connection problem. Oh, Dr. Svetkova, are you ready with your presentation?
I'm sorry, but I can't sharing my screen with you.
Yeah, I'm making you the presenter. Then only you can share your Yes, it's done. Now you can share your screen with us.
Can you see?
No, please click on the screen button. That is the third button on the bottom of your
No.
screen.
What about now?
No, it's not visible. Yes, now it's visible. You can start your presentation.
So my poster is about periodontal complications in patient with epilepsy and how it can change orthodontic treatment and any difficulties which we can see in our patients then in the orthodontic treatment patients using medications to control epilepsy.
Yeah, hello, doctor. Is there any problem? Yeah, hello, Dr. Svekova.
Hello.
Yeah.
So it's oral presentation or just poster presentation?
Okay, we are waiting for the explanation of the poster. As generally in poster presentation, the speaker needs to explain about the poster.
Okay, I see. I'm sorry. So we examined 18 patients with the diagnosed epilepsy who came to our clinic for consultation and orthodontic treatment. And we found that more than half of that patients have periodontal problems. And the most cases were hypertrophic gingivitis. And the orthodontist must change the treatment plan accordingly to the general status of the patient and to the periodontal status, of course. The first, in our opinion, the first thing is to stay in close contact with the neurologist of the patient and the possibility to change medication with less complications in periodontium. So this is the main thought of our investigation and our message.
Okay, thank you, Dr. Svekova, for your presentation. Is anyone having any questions? Okay, I think there are no questions from anyone. Thank you once again for your presence and your presentation.
Thank you very much for your attention. Thank you.
Yeah. So by this we came to end of our day one webinar. I would like to thank all the attendees and participants of today's webinar. Hope you enjoyed the webinar and gain knowledge from the sessions, and request you to attend tomorrow's sessions too. If you have any queries, you can mail to the concerned program manager. Thank you all to one and all present here and making the webinar successful.
Thank you very much. Very interesting.